I'm Professor Darlene Riggs. It is an absolute pleasure. Thank you for choosing Riggs and Kleck. So today is all about cardio, cardio, cardio. We are going to break down this system. We're starting from scratch and making our way up. So I will start from the anatomy, physiology, and then make our way to disease processes. I'm also covering the pediatric cardiac anomalies. Normal newborn is covered under health promotion. So this will be about the abnormalities for the cardiac system in the newborn, and then we'll jump into adults. So again, welcome to Riggs NCLEX. Thank you for joining me. I'm looking forward to being able to help everyone pass NCLEX. And that is my prayer, that all of you that are on this meeting today pass NCLEX when you sit for it. And I truly, truly mean that wholeheartedly. I know the difference that makes once you pass this test. You're able to provide for your family and have a wonderful career. So I always love to see that. And I believe it's a calling for me as well. So I pray to God that each and every one of you pass the test when you next sit for it. So let's start with the heart. Now, with cardio, first thing first, you have to understand that the heart has layers. Literally, there are multiple layers to the heart. So the very first layer that you can tap into if you cut somebody open would be what we call the pericardium. So that is the sac that surrounds the heart. You will see in a moment why you need to know and understand that, because there are conditions where these different layers get infected. So the prefix of these words, whether it be peri, epi, see my cursor, peri, epi, myo, or endo, tells you where in the heart you are. So again, the prefixes, the words before, tells you where in the heart you are. So when you're doing a test question and you see a word like myo, you have to stop and think, where in the heart or which layer of the heart is that? Myo would be the muscle of the heart. So peri is the very first enclosure of the heart. Epi is the second layer. Myo is the muscle, and endo is the inner lining of the heart where blood is flowing. The word card or root word meaning heart. So the prefix tells you where, and the card tells you you're in the heart, and the suffix, the last part of the word, tells you what's going on. So if you just see ium, you're just in that section of the heart. But if you see something like itis, that means there's an inflammation in that section of the heart. So pay attention to words and be able to break words down and picture it. Even if you're not a visual learner as your priority style of learning, you still need to get into the habit of visualizing what it is that, is happening. So layers of the heart, pericardium, epicardium, myocardium, and endocardium. But if that suffix changes to itis, it tells you there is an inflammation in that section of the heart. Okay, so those of you again who are visual learners, look at if we cut out a little piece of the heart, you can see here endo, that's the inner lining. That section is extremely important. That section is important because that is the inside of the heart. That is the inner lining of the heart. Okay, where blood is flowing. If there's an infection there, that is going to impact the valves, which you see right here, which we'll talk about in a moment, and their job, right? What is their purpose? And you see here, the muscle of the heart is pretty thick, okay? And you see the peri right here. We're going to talk about when fluid accumulates there. Those are nice high-level questions. Critical thinking is required for these type of questions. And here's the parietal pericardium right here, the very first layer. So this is great stuff for you to see, to understand, and then it's going to get a little bit harder and harder. So I pray you ate, you had some water, and you used the bathroom. All right, so the goal also is to try and focus everyone for at least an hour, and then, take a break and then get your mind together and then jump at it again. That's kind of how this works. Make up your mind to not get distracted from accomplishing this goal. You need to focus on that. Life is going to happen. It just does. It happens minute by minute, second by second, hour by hour, week by week, month by week. But make up your mind that you're going to dedicate a good 2 to 3 weeks to getting to where you need to be and taking the test and passing it. All right, so we just covered layers of the heart. So now let's cover chambers of the heart. So there are 4 chambers, 2 right and 2 left. So there are 2 atriums, a right atrium and a left atrium. Okay, so if you're thinking of the heart in your body, the right is the right. But if you're looking at the heart on somebody else's chest, you have to reverse that. Right become left, left becomes right. So you figure out how you visualize that and don't change. If you're used to visualizing the heart in your chest, your right is your right, your left is your left. Stay that way. If you're used to visualizing the heart in somebody else's chest, left is right, right is left. That's just the way it is. But choose one and stick to it whenever you're doing a cardiac question. Okay? So, right atrium and left atrium, their job is to collect blood coming from different locations, but that's all they do. They collect. So they don't work as hard as the ventricles. You'll see why that matters in a moment because we're going to do EKG, and you know that's heavy stuff. So they just collect chamber of incoming systemic venous blood. That is blue blood. Okay, coming from the system, meaning it gave off its oxygen already, its oxygen poor, it is blue. Okay, that gets dumped in the right atrium right here. The left atrium collects blood from the pulmonary. It has already gone to the heart, give off CO2, pick up O2 oxygen, and the oxygen makes it red. So nice red blood gets dumped, okay, or collected in the left atrium. Now, the ventricles, obviously they're larger. They have a job. Their job is to push the blood to its direction. And we want blood always moving. When blood doesn't move, it clots. And when blood doesn't, any area of the body that does not get blood dies. Okay. So after the blood comes from the right atrium, we'll talk about the valves in a moment, and gets dumped into the right ventricle. The right ventricle squeezes and propels the blood into the pulmonary system. So imagine the lungs. That's why I give you the full picture here. So the blood goes through the lungs and it gives off the waste, which is CO2, and it picks up nutrient, which is oxygen, O2. And that nice, rich red blood comes through the left atrium and past the valves and go through the left ventricle. The left ventricle has the hardest job. So recap, the right ventricle pumps the blood to the lungs. That's a short distance. That's not a long journey. But the left ventricle, that ventricle pumps blood to the entire body. That is the chamber that works the hardest out of all four chambers. Okay, it's the left ventricle, thick-walled, high-pressured pump that propels blood into the systemic circulation. That's a hard job. Imagine every time your heart contracts, that left ventricle pumps blood to your entire body, your head, your arms, your legs, everywhere. That's not an easy thing. And that blood goes up the aorta. You see the branching. These goes to your head and your arm, and this goes to your entire body. So that is the chamber that works the hardest. Okay? Keep all of that in mind. It's going to connect in a moment. So recap, four chambers, right atrium, left atrium collects blood. Right ventricle, left ventricle propels blood. Right propels to the pulmonary system, left propels to the systemic system. Okay? So now the valves, you need to know their job. Okay? Their job is to allow blood to only go in one direction. We don't ever want blood coming back to where it came from. Never, ever. We want it to always continue, always continue, always continue. If it flows back, that's a problem. It's going to clot. But sometimes that does happen with certain conditions, which we'll talk about in a moment. But there are four valves that you need to be familiar with. Okay, so the valves that are between the atriums and the ventricles are called atrioventricular valves. Okay, and that is the tricuspid, okay, which is on the right side, and the mitral, which is also called bicuspid. So these two, as you can see, they are between the atriums and the ventricles. So they're termed atrioventricular because of where they are. And the other two, which is the pulmonary valve and the aortic valve hidden underneath here, when we talk about both of them together, we use the term semilunar because the real ones look like half a moon. They're kind of sickled like half a moon. So that's why they get the name semilunar. Why do I tell you that? Because sometimes you'll get questions where they say atrioventricular valves. If they use the words atrioventricular valve, they're talking about tricuspid and mitral bicuspid. If they say semilunar, they're talking about pulmonic and aortic. So doesn't matter which one, they prevent backflow of blood. Okay, so your tricuspid would prevent backflow of blood going back into the right atrium. Your mitral bicuspid, you see how this one has two names. So know both names. They use them interchangeably. You could get a test question that says mitral. You could get a test question that says bicuspid. So know both names. So this valve, mitral bicuspid, prevent blood from going back into the right atrium. Your pulmonary and your aortic. So the pulmonary prevents blood from going back into that right ventricle. Your aortic prevents blood from going back into the left ventricle. So that's their job. Now, there are disorders where they get stiff, stenosis, they get hard, that's a problem. Or there's conditions where they lose their elasticity, right? Some infections could cause that. Either way, that's a problem because they're not going to be able to do their job. So keep that in mind. Now, sometimes you get questions that are called hotspot, where they're testing to see that you know where you put your stethoscope to hear these valve sounds because they make these special sounds, right? So go back. So literally, they want to know as the heart contracts, where do you, the nurse, put your stethoscope to hear the tricuspid, the mitral, the aortic. So let's go over that. Those questions are called hotspots. So within this picture, you would have these invisible boxes where they're asking you to see, okay, where do you put your stethoscope, to hear these sounds. So let's go over a quick anatomy of what's going on underneath, the client's chest and skin. So you're familiar with the clavicle. These are the clavicles. This is the sternum. And of course, these are the ribs. And in between are what we call the intercostal space right here, intercostal space. So after the first rib cage, this is the first one, the space between the first and second rib is called the first intercostal space. The second one, obviously, is going to be the second intercostal space, third intercostal space, fourth, so on and so forth. Okay, so note also whether you're on the left or the right side of the sternum. Okay, so this is the sternum. Okay, so left side, right side. So now, oh, don't forget the clavicle. So with the clavicle, in the middle of the clavicle, we would say mid-clavicular. So this is fifth intercostal space, mid-clavicular. Okay, so let's go over these hotspot questions and I'll come right back. Actually, let me use this one to cover it. This is a good one to cover it. So as the heart contracts, you see these valves, they're opening and closing and relaxing. So then the test asks you, okay, where do you put your stethoscope to hear, let's choose the aortic. There's a couple of little mnemonics that people have made up to help them remember these. So you figure out which one work for you. So a good one is all physicians enjoy taking money. So I like when they're funny because it helps you remember them. So all would be the aortic. So the aortic is generally right sternobortum. So this is the sternum. This is the right side. Right sternobortum, second intercostal space. So aortic is usually here for all. Pulmonic, physician. So you just go across. By the way, the aortic is the only one on the right side. Okay, so the aortic, you would literally, you see my cursor, you would put your stethoscope here. And NCSPN says that the invisible box that's there is pretty large. I know sometimes the products you practice with in real life, the boxes are not large. And if you're a little inch out of there or nano inch out of there, it marks you wrong. It's good to know that on the real NCLEX, it's not like that. That's why I love attending these seminars that they have, because we get to ask the questions as a student. Because then I talk to students all day long. This is what I do. And students will tell me, I'm marked wrong, but I was, almost 100% in there. So it's good to know that for the real NCLEX, the box is big. So right here, right sternobordum, second intercostal space would be the aortic valve, the only one on the right side. That makes it easy, right? All the others are on the left side. So just cross over. Okay, for the pulmonary, it is still second intercostal space, but left sternal border, because this is the sternum and this is the left side. Okay. The Erb's point, you've heard of Erb's point, is third intercostal space. So remember the little mnemonic, all physicians enjoy. The E is for Erb's right here, third intercostal space, right next to the sternobordum. Okay, because this is your first, your second, your third. So there's an invisible box right there. The tricuspid is fourth intercostal space. So there's 1, 2, 3, 4. All physicians enjoy taking, taking tricuspid. There's an invisible box here you would put for your tricuspid to hear that valve. Now, the apical is different. The apical pulse is not left sternobordum. So here's the sternum. It's not left, it's mid-clavicular. That's why we have this here to show you where the middle of the clavicle is. So 1, 2, 3, 4, 5. The fifth intercostal space is where you would put your stethoscope for the atrial, right? For your apical heart sound. So great hotspot questions, but they're not considered high level, by the way. So you want to be well versed with that. So what I can do, let me put a little memo to send you the different mnemonics with that. But I always suggest that students make up their mnemonics, because when you make up mnemonics, you will not forget them, because you either using your children's name, your career, something, that matters to you where you're not going to forget the mnemonic, okay? So this is a nice little visual again of how blood flows and what's happening with the valves, so you can understand, beautifully. So here's the superior in the inferior vena cava. Here's the right atrium where blue blood, deoxygenated blood coming from the system after giving off the oxygen, gets dumped. Okay, it goes through the tricuspid valve and into the right ventricle and up the pulmonary valve through the pulmonary artery and into the lungs. So imagine the lungs on each side. At that point, when it gets to the alveoli, the exchange happens. Literally gives off the waste, which is CO2, which we blow off every time we, exhale. And then we pick up oxygen. And by the way, oxygen exchange only, here's an only. If you watch the previous recordings, those are free. I talked to you about absolute. But right now, this is true. I tell you, be careful of absolute, because that's rare cases where something is only, every, forever, all. But it is only at the alveoli we exchange air. We give off CO2, we pick up O2. It doesn't happen anywhere else. It doesn't happen in the primary, secondary, tertiary bronchial tree. No, only at the alveoli. Okay? So now that rich red blood full of oxygen gets dumped it goes through the pulmonary veins and gets dumped in the left atrium, goes past the mitral bicuspid valve into the left ventricle, up the aortic valve, and into your head, your arms, your legs, your entire body. So I think everyone is good with blood flow right now. And again, you're not going to get a specific question that asks you straightforward with blood flow, but you do need to know and understand it in order to answer the questions, the higher difficulty level questions that are coming up. Okay, so hang in there. So physiologically, function of the heart is to transport oxygen, carbon dioxide, which is nutrient, and waste throughout the body. Okay? The atrium and the ventricle, they work asynchronously in order to keep us functioning. So you know we have systole and diastole. So whenever we have systole, that's when the heart is contracting. But the heart is not always in a contracting mode. It also relaxes at one point to receive blood. So the relaxation is called diastole. Okay, where the heart is relaxing in the chambers of filling up with blood before another contraction. Okay. All right. So when you have that whole systole and diastole, there's a little something we call lub dub. The very first sound is the lub. That's when your atrioventricular valves close. When you hear that lub, they close together, as you see here in this picture. It just, whoop, that's the lub. Okay. The second heart sound is the dub. So when the semilunar valves closes, that's your dub. Okay, lub dub. And I use a lot of Adams pictures because from what I understand, NCLEX does as well. So you'll see a lot of those throughout my PowerPoints. And my PowerPoints are great, everyone. And not because I made them, but because students tell me. I remember so many students, saying, Professor Riggs, your PowerPoints are so on point after they take NCLEX. There's one young man I'll never forget because his dean told him to call me because he had failed the NCLEX a few times. And the dean said to give me a call. So I worked with him, getting him to pass the NCLEX. And after he passed, he reached out. A lot of times you all don't. I wish you would. Even just shoot me a text and say, Professor Riggs, I passed. Thank you. And that way I'll know. But he sent me a nice long message and saying, wow, your PowerPoints were so on point when it came to NCLEX. So I'm glad to know that. And that takes a lot of work, folks. It doesn't happen overnight where it just poofs into air. As I talk to students, I update, these PowerPoints. And when you see I put stuff in red, pay attention to those. Okay, so blood flow. Deoxygenated blood enters the right atrium through the superior and inferior vena cava, like you saw earlier. Okay, enters the right ventricle via the tricuspid valve, travels through the pulmonic valve to pulmonary arteries and lungs. And of course, exchange happens. Oxygenated blood returns from the lungs through the pulmonary veins and into the atrium and enters the left ventricle via the bicuspid, also known as the mitral. Okay, and then that left ventricle, as the blood enters that left ventricle, it goes through the aortic valve, and then the entire system gets oxygenated. So those of you who are visual learners and want to see that whole process, that's kind of what it looks like from a grand view. So please know and understand what I've just gone over because we are going to talk about heart failure. And you need to have that little process really down pack and understand it. And this will help with a lot of diseases that are coming up concerning the heart. Okay. All right. So not time for a break. Hang in there. This is another very nice picture. You can see the valves clearly here. So, and they're all titles. I like putting the names because sometimes you'll forget. Some of you did this a long time ago. All right, so now the heart oxygenates the entire body. Yes, that's wonderful. That's great. But the heart itself needs to also receive oxygen. It wouldn't be fair to take care of every other organ, every other system, and then you're deprived. So the heart itself needs oxygen. And it also needs to remove waste. So that happens through the coronary arteries. Okay, so with the arteries, you have the arteries of the heart that branches from the aorta. This is a very nice picture. When I found this, I was like, oh, this is perfect. So you have what's called the right coronary artery, okay, as you can see right here. Beautiful, right? Right coronary artery supplies the right ventricle and part of the left ventricle because as you can see, it's like the root of a tree, isn't it? And it wraps the heart so that every part of the heart gets oxygen as well. The left coronary artery is going to supply most of the left. So depending on which one gets blocked, we're going to talk about that, whether it be a clot, plaque, something's blocking the pathway of that coronary artery, the heart is going to be deprived of oxygen, which is obviously a problem. And then, of course, you have the veins, the coronary sinus veins, and the Tibicean veins, which helps to remove all of that waste. So this is a great picture to keep in mind. I love it. So keep in mind, the heart gets oxygen itself via the coronary arteries. So we never want that blocked. Okay, we need that passageway. This is another nice picture. So you can see here the right coronary artery, how it kind of surrounds and branches the heart. And the left, I like that this is see-through. So you can see the left here, okay, so that the heart itself can get oxygen. This is going to the lungs, and you see the blood that's going up the aorta is nice oxygenated blood. And these are branching from the aorta. So God forbid this gets blocked, that's a problem. Okay. All right. Deep breath. So that was a quick anatomy and physiology. So hopefully if you did this a while ago while you were in nursing school, this is a refresher. Okay. We have to now talk about the electricity of the heart, and then I'll allow you a short break. So let's at least cover normal EKG and then take a break because I don't want you to be mentally overwhelmed. So we just talked about systole and diastole. There are words that are used interchangeably when we talk about these things. So if I say depolarization, it's the same thing as the systole. It's contraction of the heart. If I say repolarization, it's the same as diastole or relaxation of the heart. Okay, so re for re. You know one, you know the other. It's just that simple. Repolarization, relaxation. And if you want to think diastole as dying, I've heard students use that as well, whatever works, okay? So every time the heart contracts, there's an electrical firing that is recorded on an EKG strip, which we're going to talk about, okay? Students often ask me, what's the difference between EKG and ECG? It's the same thing. We use the term ECG when we're writing, right? And writing, and then we use EKG when we're speaking. That's really the difference, but it's the same, okay? So the firing of the heart begins at the SA node. That's considered the heart's pacemaker. The moment conception happens, right? Egg meets sperm. That little, pacemaker of the heart starts. That's the SA node, okay? And then imagine this as a domino effect, okay? It's like you drop one domino, it's going to go and drop the other dominoes. That's really how the firing of the heart is. So once the SA node starts, it branches or goes on to what we call the AV node, right here. So it's like, okay? And then from the AV node, there's a branching that happens, right and left, okay, at what we call the bundle of His right here, bundle of His. And then at the end of the right and left, branching is what we call the Purkinje fibers. At the very tip are the Purkinje fibers. So that's the firing of the heart, okay? So again, imagine it like a domino effect or steps, okay? The conducting system of the heart starts at the AV node, then the SA node, then the AV node, then the bundle of His, right and left branching, and then the Purkinje fibers at the very end. We don't want any abnormalities in any of this process, but of course, we don't get beautiful, awesome patients, right? We get critically ill, sick, so something goes wrong with these at times. Sometimes the firing or the lack thereof is happening in the atrium. Sometimes it's happening in the ventricles, right? Sometimes it's both. So we are going to talk about abnormality. So we're going to cover a normal EKG, and then we'll cover the abnormal EKGs, okay? So here's another nice, beautiful picture of that. Your sinus node right here, and then the firing continues all the way to the end of the Purkinje fibers, okay? So visualize that. So now your sinus node is what sets the whole control of the the contractions of the heart, right? The depolarization of the heart. So if that is not going well, then the rest is going to be impacted. So this is somewhat of a master, okay? So the sinus node is the master of the heart, but the master of the heart is controlled by the nervous system. And if you remember, the nervous system comprised of the sympathetic nervous system and the parasympathetic nervous system. Okay? Remember fight and flight, feed and breed. I'm bringing you back to the classroom. But that is what's controlling this master. So the master has a master. It is what it is. Every time the atriums and the ventricles contract, that is recorded on our EKG strip, right? So every time the atriums contract, that's the P wave. I'll go over that in detail and show it to you on the strip. So hang in there. Every time the ventricles contract, that's the QRS. And the T is the relaxation of the ventricles. Okay. And we do need to know the acceptable amount of time these are supposed to last, right, and take. So it does get a little bit complex. So to recap, and I'll recap again and again and again. So don't worry if you don't get it. The repetition helps you to remember. So atrial depolarization contraction is the P wave on your EKG strip. Ventricular depolarization contraction is the QRS on your EKG strip. The T is the ventricular relaxation, repolarization. Okay, so this is recorded on your EKG strip. Okay, so now you do need to know how long a normal PQRST is supposed to last. So on a normal EKG strip, by the way, it doesn't matter where you go, the strip is the same, whether you're in Canada, Guam, Hawaii, it doesn't matter because we all use the same strip. So on NCLEX, so don't worry. That's why you're able to sit for the test under different states and not worry. So by the way, you can only get questions, or the NCLEX is based on what's done across the district. So for example, every state that administers the NCLEX exam, right, under NCSBN is under the same, jurisdiction. So that means you can only get NCLEX questions where the answer is the same no matter what state you sit for the test, what state you choose to practice. That's why we have compact licensures, right? So you cannot get an NCLEX question where the skill, the procedure, the policy is specific to a specific hospital. It has to be across jurisdiction, which is great. So we all are supposed to follow that same, model. So everybody use the same strips, okay? So P wave is your atrial contraction. So the question is, how long is that supposed to last? So you have to be able to read an EKG strip, okay? So normally you get a 6-second strip, right? The test questions you get, it's going to normally be a 6-second strip. Half of it is obviously going to be 3 seconds. So the question is, how long or time-wise, how do you measure this strip? So if you look, this dark pink section, you can see my little cursor here. I'm circling the dark pink. That big box, that's what it is. It's a big box. Inside this big box are 1, 2, 3, 4, 5 little boxes. And every little box is worth 0.04 seconds. Okay, so think about that. Every big box, this is a big box pulled out so you can see the big view. Every big box has 5 little boxes, and every little box in time is 0.04 seconds. So if you multiply that by 5, a big box is 0.20 seconds. Keep that in mind. Repeat one more time. Every big box where you see the dark pink has 5 little boxes. Each little box is in time worth 0.04 seconds. So you multiply that by 5 in order to get the time frame of a big box, and that is 0.20 seconds. Okay? So here's another view of that. 1, 2, 3, 4, 5. So that's 0.04 times 5 equals 0.20 seconds. Okay? So keep that in mind. So recap. On an EKG strip, you have 3 distinct waves that you need to be familiar with and worry about for NCLEX questions. Now, if you decide to go on a telemetry floor, you are going to be required to take an advanced, right, telemetry course in order for you to work on that unit. And then you're going to go into so much more detail for an EKG to be able to read it and, safely care for clients. But for NCLEX purposes, we're going to worry about these 3 distinct waves, P, QRS, T. So recap, P is the atrial contraction. QRS, ventricular contractions. T, ventricular relaxation, repolarization. Okay, now the time frame. How long is a normal P wave supposed to last? Okay, so P wave is the atrial contraction or depolarization. Okay, very different from the QRS. It is supposed to last no more than 1 to 3 little boxes. So the biggest or the longest time you want a P wave to take are 3 little boxes, which would be 0.12 seconds. Some books may say 0.1. This varies a little bit from book to book to book or sources, but memorize the 1 to 3 little boxes for a P wave. Okay? So when you look at an EKG strip, one of the first questions you need to ask yourself is, are there P waves? If there are no P waves, you know that's an atrial problem. And then after you see P waves, if you see P waves, are they happening regularly? That's normal. That's what we want. We want them to come at the same time. We don't want them to come too fast or too slow. Are they happening regularly? And then do you see a P for every QRS? That's normal. That's what we want. PQRST, 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 PQRST. Do you have a P for every QRS? Okay, minimally, those are the questions you need to be asking yourself. So now let's go to QRS, which is ventricular contractions. So same thing here. You don't want a QRS lasting more than 3 little boxes. Minimum you want is at least 2 little boxes, so 2 to 3. So for the P is smaller, we want 1 to 3 max, but for the QRS, you want 2 to 3, because if it's not at least 2, it's going to be too close together, right? We want at least 2 to 3. Okay, that's a normal. And every EKG strip, you're asking yourself, do you see, QRST, QRST, PQRST? You don't want to be missing. We're going to talk about conditions where that happens, but the norm, okay? So here, because of the larger tissue, which I talked about earlier, the QRS complex is larger. They're larger muscles having to actually do jobs, propel blood, okay? So they need to generally last a little bit longer. Okay, at least 2 little boxes, maximum 3. If it's lasting longer than that, there may be some blocks. We'll talk about some of these conditions in a moment, okay? So sometimes you'll ask to know, you need to memorize the normal time for a P to R. Now, here's the thing, everyone. I know it says P to R, but you don't actually go all the way to the R to measure this. Okay, just know the book. Don't argue this. And there are cases like that, folks, where it just is what it is. Accept what the book says and pass your test question. Because I'm with you. I get it. Because we're telling you P to R, but why aren't we going all the way to the R? And if you weren't taught this in the class and you get a question like that, you're looking from the start of the P all the way to the R. No, you're literally stopping right before the Q, like you see here in this picture. The beginning of the P to the beginning of the Q. I know it says P to R. That is normally supposed to last 3 to 5 little boxes. Okay? 3 to 5. 1, 2, 3, 4. Now, if that is lasting more than 5 little boxes, you have a block that is abnormal. So you want it between 3 to 5 little boxes. Okay? So usually when you have a prolonged P to R, like you're looking at your EKG strip and you see it's like, 6, 7, 8 little boxes, that's usually a first degree block, which we're going to talk about in a moment. Okay? Not normal. We want our P to R to be between 3 and 5 little boxes. Okay? 12, 0.120 to 0.250. So when you're reading an EKG to figure out if it's normal, you're asking yourself, yeah, and you're doing the math, you're counting 1, 2. Okay? So again, from the beginning of the P to the beginning of the Q, even though it says P to R. All right. So again, don't argue, just accept it, pass your test question. You don't care that much. You really don't. I say this to students all the time. Yeah, you don't care that much. What does the book say? How do I get my test question correct and move forward? Okay? All right. So there aren't many questions on the ST segment, so don't spend too much time on there. It's the P, the QRS, and the P to R, okay? Interval that you need to spend the most time on. All right. Now, we are going to, I want you to go ahead and take a short break, okay? So I pray you're not overwhelmed. So get a snack, drink something, use the bathroom. Let's say about 5 minutes. Hopefully that's enough. Don't get distracted. It's not time to do the laundry. Okay? Do not get into something that's going to take you more than 5 minutes. All right? All right, everyone, let's resume. So we are about to go through a normal EKG. Well, we did do that. We went through a normal EKG and we are going to get into some abnormal EKGs. So first thing first, always, always, always assess your client first. And I've seen so many test questions where students miss that. It's just a disconnected lead and students are ready to code the client. So you always want to assess your client first before dealing with the machines or the equipment, whatever it may be. So keep that in mind always, because remember, you're client-centered, okay? So we just went over a normal sinus rhythm. Everybody should be good with that. You should be good with how long a P wave lasts, how long a QRS lasts, how long a P to R lasts. Before we continue, let's go over a few terminologies that you need to be familiar with. So, because remember, vocabulary is extremely important, okay? So you have to build your vocabulary base. The moment you see a certain word, you know what they're talking about. So since we're talking cardio, these are some of the terms of the heart that you need to be familiar with. So I just went through a whole cardiac cycle earlier, and there are some vitals you need to memorize. You already knew that, okay? So we want regular and in sync rhythmic to the heart. Every time you have a complete beat, that's a cardiac cycle, right? Complete beat. And the average we want is 72, but I know you memorize 60 to 100, yes, but the average we want is 72, which is great. So you also need to understand the word stroke volume. Every time the heart contracts, we want a certain percent of blood leaving the ventricles. If we don't have a therapeutic, the right amount of blood leaving the ventricles with every contraction, with every ejection, remember that's the job of the ventricles, to eject, right? To send the blood to its prospective destination. If we don't have the right amount leaving, that's a problem, because when blood stays or goes back, it clots. Okay, so the cardiac output, So let's back up. The stroke volume is the volume of blood ejected from one ventricle with every contraction, with every beat. That's the volume. Volume is, fluid, right? And cardiac output is the amount of blood that one ventricle can pump each minute. And it's a lot, folks. It's 5 liters per minute, which is a lot. And that's just with you not even going up the stairs. Okay, that's a lot. So minimally, we want at least 60% of the blood in your ventricles leaving the ventricles every time your ventricles contract. At least 60%. Okay? So ejection fraction is a measure of the percent of blood leaving your heart each time it contracts, and we want at least 60%. So if you get a test question and the client has an ejection fraction of 25, that is severe impairment of their ventricular system function. That is somebody in heart failure. So know that and understand that, okay? So sometimes you also get an EKG strip and you'll ask what's the client's heart rate based on that strip. So you need to be able to do that as well. So we know the heart rate is the number of times the heart beats per minute, and we memorize our vitals, okay? And that is always, here's another absolute. I told you, pay attention to words like that. The heart rate is always relevant. That tells us whether our client is doing well or not. So that is an always relevant vital, okay? So there are different ways to calculate the heart rate from an EKG strip. So let's go over a couple different ways. I know some of you, while you were in school, your instructor may have taught you one way or another. So whatever way you learn while you were in school, if it works for you, don't change, okay? Of course, if it's not working, then I would advise you to change. Okay, so on an EKG strip, one of the most accurate ways to measure heart rate is to look at your R to R interval. So QRS, the R in the QRS, the tip of your QRS, you want to count the small boxes between an R to R interval. Okay, so the R to R is from one R to another R. It's just that simple. Okay. So you take the beginning of one QRS, that R from the QRS, and count the number of little boxes up to the next R. And then you're going to divide whatever that number is by 1500. The 1500 is a formula. It never changes. So here's an example of that. So let's recap before we do that. So one method is to look at R to R. So you are literally going to count the number of little boxes from one R to the next R. See, one R to the next R. You literally count it, but you know a big box has 5. So this is very simple. 5, 10, 15, 20. That makes it very easy because these are large boxes, and then you can count the little boxes. So this would be 22, right? 5, 10, 15, 20, 21, 22. Okay? And then you divide that by 1500. This is a standard number. It doesn't change. So that's one way. Okay, another way is to count how many QRSs you have within your 6-second strip. Remember, you're always given a 6-second strip. So literally, how many QRSs do you have? Okay, and you multiply that by 10 to get the client's heart rate. So this one is great, counting the number of QRSs and multiplying by 10, whether the client is regular or irregular. Okay, but your R to R is best if they're regular because you're looking at just one R to R versus the entire 6-second strip. So this method, R to R, is great for regular rhythms, whereas counting the number of QRSs and multiplying by 10 works for both regular and irregular. So here's a quick example about the R to R. So if you count here from R to R, 26 little boxes, you do the math, 1500 never changes. This client is bradycardic because their heart rate is below 60. Okay. And here's another example, count R to R. We counted 12 little boxes. So you divide that. 1500 is your standard. Don't forget that doesn't change. So this client is considered tacky because it's 125 beats, which makes them tacky. Okay. So those are, minor stuff. So now let's get into abnormal rhythm. Now, everyone, there is a possible 29 different EKG strips that you could be asked about on NCLEX. Obviously, we don't cover 29 strips. We cover the most common one, the most frequent ones, the most relevant ones that you'll question on. But there are a lot of EKG strips that you're asked about. Okay, and you need to be familiar with quite a few of them. We're going to do the blocks, we're going to do asystole, we will cover atrial, we will cover, both atrial flutter, atrial fibrillation, VTAC, VFib, right? Those are the very common ones, and some really rare abnormal ones, but I cover them because I know they're on your NCLEX. Okay, so these are the others. So just be familiar with. So arrhythmias or dysrhythmias. So we're talking an irregular heartbeat, okay, is an arrhythmia or dysrhythmia interchangeably. Doesn't matter. They both mean the same thing. You can have that and have your heart rate be irregular and have a normal, between 60 to 100 beats. That happens too. Don't think you have to have both. You could have one or the other. You have irregular, but with a normal rate. That happens. Okay. So if I ever say you have something memorized and you don't, please memorize it. Okay. And also remember I mentioned this is new vocabulary. So you have to know exactly what I mean when I say tachycardic, right? That means greater than 100, or Brady, just like we saw earlier. So similar thing with, for example, when I teach fluid and electrolyte, I tell students be familiar with the terms because I may not always say your sodium is high, but I may say hypernatremia. You see, so it's a language that you have to be familiar with, and it's a lot of vocabulary words. So every time I'll mention that each time so you don't get thrown off, but you have to build that vocabulary base. Okay. Before we continue with abnormal heart rhythms, you need to know the difference between defibrillation and cardioversion. Okay, so when we say we are using cardioversion or cardioverting a client, the heart still has a rhythm. Okay, so the job of shocking that client with a low energy vault, right? Low energy shock is going to be to synchronize it. But there's a rhythm. I have a rhythm. So I'm going to jump start, right? So we can get a normal. So it is medical, obviously, of a quick low energy shock to restore the rhythm back to normal. We use those for irregular heartbeats, like atrial fibrillation, we're going to cover in a moment. So in AFib, one of our priority is cardiovert, right? Cardioversion. There's still a rhythm. The atrial fibrillation is a rhythm. It's an abnormal rhythm, but it's a rhythm. So we can do that, physically with the energy vault, or we can do that chemically with drugs, with medication. Now, with defibrillation, there is no pulse and they're unconscious. Okay, so with ventricular fibrillation or pulseless VTAC, we generally, want to defibrillate them. Now, there's a lot of cities and states and other places who make it mandatory for certain businesses and organizations, especially if you have a lot of people crowd in your under your roof, they make it mandatory for you to have the AED. I know a lot of cities have passed this, and it makes sense because this saves lives. It makes sense to do that. So hopefully, if you're not compliant, you get fined. So I'm sure most people, if not everybody's compliant, especially large buildings, and people need to know where these things are as well. So recap, cardioversion, you still has a rhythm. It's a low energy shock to restore back to normal rhythm. great for atrial fibrillations. Okay. Defibrillation is done when there is no pulse, client is unconscious. Okay. Very true for pulseless VTAC. Okay. So they're different in the energy that they produce. Okay, especially if you have a heart that has stopped or is quivering. Quivering is not an actual contraction. Okay, if you're defibrillating, that is powerful shocks. They're not low voltage. Okay, to correct that rhythm. And the the chemical drugs that we use, of course, they're IV. Your first line defense is ibutylide, which is Corvert, but memorize ibutylide, please. Remember, you are always focusing on your generic names because NCLEX says they're more likely to give you the generic names, okay? They might do drug classification, but the generic name is what you should expect. Other drugs for long-term would be amiodarone, verapamil, diazepam, which we'll talk about in a moment. But first, we want to do ibutylide. Okay, so the way I teach the abnormal cardiac rhythms, I do the Brady's first, and then I do atrial problems, then I do ventricular, and then I do the odd ones that really don't fit under any umbrella. So I organize it like that. So we're going to do all Brady stuff first, which makes sense. It's very organized. So you'll know the drugs for Brady. And then we'll do ventricular, but we'll do ventricular with atrial problems first, and then we'll do ventricular with with I'm sorry, we'll do tachy with ventricular problems. So we'll do the tachys with atrial problems, and then we'll do the tachys with ventricular problems. So it's organized like that because this is a monster topic. No matter how I slice it, it's heavy. It just is. So my job is to uncomplicate it as much as I possibly can, but it is a complicated topic, okay? All right, so just brace yourself. Okay, so the very first one we will cover is sinus bradycardia. So this is a client whose heart rate is less than 60 beats per minute. You only, only, only treat this client if they are symptomatic. If you watch my test taking strategies, remember I want you to always ask why. Why do we only treat sinus brady if they're symptomatic? Because there are clients who this is their norm. Your athletes. So you get a test question, it's an athlete in that test question, process that information. That is not given to you for no reason because the person that makes the test question is an athlete. No. If I give you a test question and there's an athlete in there, you have to wonder why. If you watch my test taking strategies, you already know this. Pay attention to age, developmental stage, culture, occupation. So your athletes, they normally run Brady and they're fine. We only treat if they have symptoms, and your treatment is going to be atropine. It's that simple. You will not miss this test question. So that's your first, very easy. And you see here, if you look how far apart your PQRS, PQRS, PQ, they're very far apart, tells you this is a Brady client. Okay, let's cover the next Brady problem. It's a first degree block. So this is an atrial ventricular block, a first degree block, which I mentioned a little bit earlier. And I mentioned your P to R interval when I mentioned this. So this is a client where you are going to look at the time from your P to the beginning of your Q. So if you were to count these little boxes, 1, 2, 3, 4, 5, 6, almost 7. That is prolonged. So you know this client has a first degree atrioventricular block when the P to R interval is lasting more than 5 little boxes. There is a prolonged conduction between your SA and your AV node. That's a problem. A number of situations could cause this. Drugs, infection, rheumatic fever, endocarditis, which we'll cover. Okay, so that's a atrioventricular first degree block. Now, there are second degree blocks, but there's also second degree type 1 and second degree type 2, and of course, third degree. So let's go over second degree type 1 and second degree type 2 and compare them so you don't mix them in the future. So a second degree type 1, this client's heart rate is irregular. That is the first major difference for you to be able to look at a strip and tell if it's a second degree type 1 or a type 2. So in a type 1, the R to Rs do not equal. They're irregular. In a type 2, they are equal. It's a normal EKG where you have your QRS coming at the same time. Okay, that's how you tell regular and irregular. So that's number 1. So first degree irregular intervals of PR, and then boom, you drop a heartbeat. Literally, you fail to conduct a P wave. As you can see here, nada. They drop a heartbeat. So irregular. So if you look at your R to R, you will see that the P to R gets longer and longer and longer, and then they drop a heartbeat. See here, the PR interval gradually increases. Look at here. That's close. Look how that widens. Look at how that widens, and then nothing. That's how you see that you're dealing with a second degree type 1. So repeat. Second degree type 1 are irregular. So wider, 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 and then boom, they drop a heartbeat. Literally, there's no QRS. Nothing. And if you count your P to QR, they don't equal. That's type 1. Okay. Type 2, normal, PQRST, PQRST, and then they drop a QRS. You don't see this getting wider, you don't see this getting wider, you don't see this getting wider, and then boop, they don't have a heartbeat. This is usually something happening with the Purkinje fibers. There's dead tissue, ischemia. So those clients need a pacemaker. Okay. Type 1, if they're symptomatic, we're going to treat with atropine. But if they're not symptomatic, because sometimes that's just from aging, it's usually benign, not a big deal. It's part of getting old. But if they don't have any symptoms, we don't do anything about it. If they have symptoms, atropine. But type 2, because it's ischemia, they're going to need a pacemaker. We'll talk about pacemakers in a moment. Okay. Now, third degree, there is definitely damaged tissue and it's irreversible. This is usually after a myocardial infarction. You count your P and Rs, they don't equal. Okay. Ventricles do not pump fast enough to maintain cardiac output. They definitely need a pacemaker. You see here, they're dropping heartbeats. That's a third degree. Only treatment at this point is a pacemaker. Okay. So we'll talk about pacemakers. But let's look at in general. Now, everybody wake up. Especially because of next generation NCLEX. If you watch the previous webinars, please watch them. I talk about the clinical judgment model. And I show you the 6 steps of the clinical judgment model. and you knowing how clients present and can link information is so key to passing this exam. So right now we need to go over causes and signs and symptoms of the sinus Brady conditions we just talked about. You need to know the potential cause. You need to know how the client presents, the signs and symptoms, because that's what they're testing to see that you know. So this is where you slow down and don't study where you're distracted, everyone. That is a big mistake. Some topics, it may not be a big deal. You can just put me on, put the the audio on and listen because they're not heavy material. Yeah, some topics are like that. It's just FYI. They're not heavy. You don't need to stop and think and, process. But topics like this, you do need to study in your closed area, no distraction. The world doesn't exist. You don't know if it rains or snows because you're zoned in. And this is this section, okay? So sinus Brady, heart is beating too slow. What could cause this? So here they are. Hypoglycemia. You know your prefixes. Hypo, not enough. Hypoglycemia. Their blood sugar is low. Hypothermia. They're cold. Hypothyroidism, right? Endocrine. Of course, previous cardiac history. The heart is not at its best. Some medications. Toxic exposures. MIs or previous MIs. The heart, again, is not at its best. So then they're at risk of these Brady problems. How do they present? How do they look when they're Brady? Because I just told you earlier, you don't treat unless you see signs and symptoms. You have to wonder, what are these signs and symptoms? Syncope. And when you see signs and symptoms like that, safety has to be crossing your mind. Someone has syncope? Yeah, there's a safety little tag that is attached to that. They're dizzy, safety. Chest pain makes them a priority. Shortness of breath makes them a priority. And they'll tell you, I can't go to the mailbox without being tired, right? I can't go up the stairs. They can't because the heart is not functioning at its best. They're cool, clammy, which goes with the whole hypoglycemia, hypothermia. You remember hypoglycemia, cool and clammy, need some candy? I have a few little mnemonics memorized. Yeah, so it makes sense. So you should be good now with the Brady causes and signs and symptoms. Hypoglycemia, hypothermia, you see a lot of hypo. And of course, imagine your heart not pumping at least 60 beats, syncope, dizziness, chest pain, shortness of breath. You don't have enough red blood cells flowing through. Makes sense. Okay, so now let's go over risk and medical treatment. So anytime you Brady, you have a reduced cardiac output. It makes sense. Your heart is beating less than 60 beats. Yes, that's less oxygenated blood going throughout your entire body. So you are at risk of a reduced cardiac output, not enough blood. We just talked about cardiac output. Now, step 5 in the clinical judgment model is the step that is asking you how to treat these clients. They want to know that you know the treatment for these conditions. So not only do you need to be able to link, put your plan together for the client, but you have to execute. So we treat the Brady's with atropine, which we talked about earlier, only if they're symptomatic. If the client is right, blood hemodynamically compromised, not enough blood flowing through, then yeah, we may need to pace. Yeah, pacing. But treatment is always based on symptoms. That's the first thing you want to look at in your question. Because remember, you get these evolving case studies, right? So you have to go back to your beginning scenario and then see if you get new information, see your signs and symptoms to know whether you're going to be treating or not. So in addition to that, your nursing interventions. What are some of your nursing interventions for your Brady client? Question number 1, do I have symptoms? You know, the nursing process tells us we're always assessing. And I told you from the very beginning, always assess your client first, not the machine, not the device, your patient. Do you have symptoms? Right? Are they saying I'm dizzy? I'm short of breath, my chest hurts, right? Are they saying these things? There's objective and there's subjective data. Subjective is what the client says to you. Objective is what you observe, you assess. Assess your client. Are there symptoms? If there are symptoms, we need to treat. If they're asymptomatic, no symptoms, watch them. Put oxygen on them. Put a pulse ox on them. Their blood pressure and their heart rate, I mentioned earlier, is always a vital assessment. If you don't already have a large bore IV, put one on. Then you call the physician. You see how the physician is not first. There's so much you need to do. So be careful calling the physician. If you call in the physician, all of this has already been done. There's nothing else you can do. Okay? That was all Brady. Now we need to go to Taki. And we're going to do Taki with atrial problems first. And then we'll do Taki with ventricular problems. It's organized that way for a reason. Again, this is a monster topic. So I found a way to just organize it really well so you don't get overwhelmed, okay? So now we are going to talk about tachyarrhythmias with atrial problems, okay? So our first one is sinus tachy, heart rate more than 100, okay? So your sinus tachy, yeah, well over 100. This could be from a number of reasons, literally. Could be from exercising. Anxiety causes you to be tachy, okay? Another common cause, hypovolemia, because your heart is trying to compensate. You're losing blood or fluid. Your heart, we're made that way. Your heart is going to try to compensate until external measures can be taken, which is great. So the moment you start losing too much blood or fluid, your heart is going to beat faster to get more oxygenated blood because it doesn't have enough. And then your sympathetic and parasympathetic nervous system gets activated because we want blood going to the vital organs. That's your fight and flight. Thank God for the way the body is built. Thank you, Lord. Your feed and breathe, right? Your gut, your urinary system, it slows down. They're just not the vital organs. Okay. And usually you won't see clients with symptoms until it's well above 140. Okay. That's when the diastole, remember the lub-dub, systole and diastole, that's when the diastole is impaired. Now, a couple of ways you can tell if a client is tachy, you can just look at the number of boxes. The less you have or closer you have your R to R, then the more tachy the client is. Sometimes students do memorize this. I think you should just look at your strip and figure it out. But if this works, this works. Find what works. One box, you're talking 300 beats. If you're looking at a R to R and there's only one big box between them, yeah, that's tacky. 2, 150, 3, 100. See, we want at least 3, like you see in this picture here. 1, 2, 3. That's somebody whose heart rate is about 100. Okay, 4, 75, 5. So if this works for you, then by all means use it. Okay, so the treatment for this is to eliminate the cause, but let's go over some other potential causes. Okay, so sometimes there is true damage, to the heart tissue. Could be previous heart disease. They could be hypertensive, right? Hypertension, fever, that causes stress itself. Those who consume excessive amount of alcohol, excessive amount of caffeine. Some of you probably very familiar with the caffeine, you palpitate, nicotine, and of course some drugs, especially street drugs, recreational drugs such as cocaine, crack, and those type of things. Sometimes this is side effects to medication. Pain causes you to be in a tachy mode. Electrolyte imbalances, hyper. You saw earlier for your Brady, it was hypothyroidism. Now for tachy, hyperthyroidism. And when you go over my endocrine teaching, I say the same thing. Okay. So make the information make sense and connect it. So number of causes. So we look at the underlying cause. If it's the fever, we treat the fever. If it's the stress, you got to find ways to decrease stress. If it's the caffeine, you want to, taper down and then get off of it. The alcohol. So a lot of these are modifiable. Remember those terms. Modifiable versus non-modifiable. So modifiable, we can do something about, right? We can decrease our stress. That's not as easy as it sounds, but it's modifiable. We can decrease amount of alcohol, caffeine consumed. Like some of this is modifiable. Examples of non-modifiable is culture. You're born into your culture, right? Um, Aging, you can't change those type of things. So male versus female, like, some things are not modifiable. It's just the way it is. Now, signs and symptoms, how do they look? How do they present? You have to spend a moment under these umbrellas. They're going to be dizzy, safety, shortness of breath, priority, lightheadedness, safety, rapid pulse, always important. We're always taking the blood pressure and the pulse. They're palpitating because we're talking tachy, chest pain, syncope. Do you see how there's some commonalities, right? So you need to know the difference because I mentioned syncope and chest pain and shortness of breath, right? Earlier with Brady. Let's go back just so you see I'm not making this up. And you need to pay attention to that. Look, under Brady, we had syncope, right? We had the dizziness, we had the shortness of breath, and we had the chest pain. Let's go to tachy. Tachy, dizziness, shortness of breath, chest pain, syncope. So you need to know what makes them different. And that's why you have a client that comes in. We don't want to mix the two. So what's going to tell you the difference between the two is the heart rate. Okay, so go back real quick. The heart rate and the cold clammy is a big difference. You don't have that here. Okay, so you have to, you see, this is the whole closet moment. This is the whole cue card moment. This is the whiteboard moment where you put these next to each other and you see the difference, because a client that walks into the emergency room will not tell you, they won't know their Brady versus tachy. Further assessment, right? Validating what we see will confirm, knowing the difference between the two. Because I could give you one of those new next gen type of questions and put all of these signs and symptoms here. And I want you to differentiate the Brady from the tachy. That's how you have to study and think. Actually, that's a very good question. I'm going to put that together. But that's what you have to be able to do when you're studying. Okay, I'm done drilling you. Forgive me. Okay, so now let's talk about risk and treatment. Okay, for tachy. Because the heart is beating so fast with tachycardia, that doesn't leave enough time for filling of these ventricles, which is a problem. Okay, so you still have a decrease or a fall in cardiac output because of that fast. So same problem with Brady, but different reasons. Same problem. They're both decreased cardiac output. That's the risk. Decreased cardiac output. That's the complication. That's what we don't want. But for different reasons. So the Brady, it was too slow. The tachy is too fast, but both causes a decreased cardiac output. So that causes a demand for more oxygen. Either way, whether it's Brady or Taki, there's a myocardial oxygen demand. So the heart wants more, it needs it. So if we don't address this, tissue dies. Myocardial ischemia or infarction, we don't want that. We need to find the cause and get rid of it. So we find the cause, and that's how we treat this. We look for the underlying cause. And in your scenario, you're given these underlying causes. Okay, so now let's talk about intervention. I'm going to sound like a broken record. Always assess your patient first. Do I have symptoms? Is my client stable? And you need your blood pressure and your heart rate to determine the answer to that. Then you're going to give oxygen, put the pulse ox on, monitor that blood pressure and heart rate, start an IV, preferably large bore, then call the physician. Now, I hope you just renewed your CPR card and your ACLS card. If not, you have to go over my PowerPoint, my CPR PowerPoints, okay? Because you do need to have that. And if you just renewed it, great. So again, we want to look at the cause and then remove the cause. If it's a fever, we're going to give the Tylenol, the acetaminophen, or the ibuprofen. Okay, if it's being caused by some type of stimulant, caffeine, then yeah, get rid of it. Over-the-counter med, herbs, crack cocaine, yep, get rid of it. That's why it's always important to do what we call a medication reconciliation. Mrs. Jones, bring in all your medications. What are everything that you're taking, including herbals? Often people don't think herbs matter. Yes, they do, and they impact prescribed medications. Anxiety, that requires a little digging into to see what's causing that anxious behavior. Are they septic, right? Sepsis will cause that. Anemia will cause that. Hypotension, MI, heart failure, hypoxia. We want to look and see and eliminate all of that. And you want to look at your QRS, right? They're going to be narrow. We just talked about that. We'll talk about the vagal maneuver in a moment, but you're going to see a regimen, right? If it's true, like even as we try and remove the cause, you're going to see a regimen. So we're going to bring the adenosine. Now you're not going to see me say atropine here because we're not talking Brady. This is tacky. So it's going to be the adenosine, the beta blockers, the calcium channel blockers, cardioversion we just talked about. We may bring in a lot of antiarrhythmics, right? Procainamide, amiodarone, sotalol. Those are the drugs now. No atropine here. Okay? So that's for your tachy. We're still in tachy. So now let's talk about supraventricular tachy. The name tells you a lot. So what's happening with supraventricular tachy, sometimes you'll see SVT, same thing. So you have a signal that fires, right? It goes through, but it comes back. We never want that. We need you to keep going in your same direction. We need those dominoes to, it can't be a going back, no way. So this conduction signal loops and it re-enters the atrium. So this is still an atrial problem, but obviously it's going to impact the ventricles because remember, we're still on tachy, but atrial problem. So that causes a rapid heartbeat, well over 140. Very, very narrow QRSs, as you can see in this picture here. We have to treat this. There's no if you have symptoms, don't have symptoms, we treat this. You've heard me say that a lot, especially for the Brady stuff but no, we're treating SVTs. Okay? And you're giving adenosine IV push. Okay? PNs, you're not doing this, RNs. So if you went over The test is not different for PN versus an RN. There are two client needs categories that are different: management of care and pharmacology. Okay. But as far as basic care, reduction of risk, health promotion, psychosocial, it's all the same information as far as the content, the knowledge. It differs for RN and PNs when it comes to delegation, right? When it comes to scope of practice, when it comes to medication administration. There is no state that allows LPNs to IV push. Okay. Only RNs. It is not under. So I remember reading an article many years ago where this agency allowed PNs to get trained to do IV pushes. Shut down. Big, big no-no. Okay. So I go in details with that under management of care, coordinated care, which is where it belongs. But RNs, you're doing this. Okay. So let's go over causes and signs and symptoms. You kind of see already I have a routine and I'm very organized, and I even want you to, when you get your test question, to picture this. Okay? So first we go over the pathophysiological process as to what's happening with the condition. Okay, then we cover what causes it. Then we cover signs and symptoms. Then we cover nursing intervention, right? With the treat. So because your test questions are similar like this, building volume. So you kind of need to study like that. Okay, what causes supraventricular tachy? A number of things. Find the underlying cause and get rid of it. So similar to regular tachycardia earlier, the stimulants. Not enough oxygen, hypo, not enough oxygen, stress. Here's a new one I haven't mentioned, hypokalemia. So that's why, routinely we do a chemistry panel. Because the moment we do a full chem panel, we will see that hypokalemia, right? Lesson 3, you're memorizing 3 to 5.2. Some books about 5.0, depends on the source. But you'll be able to see they're well hypokalemic. And we fix that. If that's what's causing it, we fix that. We fix the problem. Arteriosclerotic heart disease. So we would want to pull an extensive lab to see the HDL, the LDL, the full cholesterol, and we can do other diagnostic tests to be able to see if there are these underlying heart diseases that are blocking, right? So those are the causes. So a few of them, again, are similar to a regular, tachy client, not a supraventricular, with the underlying cause, with the stimulants. Again, it could be caffeine, it could be cocaine. A number of stimulants could be causing this. Hypoxia, not enough oxygen, could be causing supraventricular tachy. Hypokalemia, not hyper, folks. Don't mix those prefixes. No, it's hypo, process is hypo, visualize hypokalemia. Now, how do they look? How do they present? They're palpitating, obviously, because we're talking tachy. Pressure, tightness, pain to the chest, lightheadedness, dizziness, safety, syncope, safety, shortness of breath, priority. They say, yeah, my heart's pounding. That's how they describe that. They're sweating. And they feel like it's radiating to their throat, where they say, oh, my throat feels tightness and fullness of the throat. Yeah, they're tired. By the way, your cardiac client, your priority is to not stress the heart. You're going to see as we continue, when we get into the actual, disease, you will see how there is a commonality. I'm going to sound like a broken record. Decrease the workload of the heart, decrease the workload of the heart, decrease the workload of the heart. Do not stress this client's heart. Any little, they're exhausted, they're coding on you. Okay? Another sign and symptom with this is an excessive urine production. So we definitely want to make sure, we address that. Let's look at risks and treatment, which correlates with this. So if this continues, complication, the heart is going to fail. They're going to go into heart failure. Okay, if we don't address. That's why I tell you we're treating this one. It's not whether you symptom, yep, we're treating this one. So we want to make sure our client is stable. We're going to look at the blood pressure and the heart rate. With the vagal maneuver, that's contraindicated if there's any type of blockage. Carotid massage is also contraindicated if there's any type of blockage. We can also sometimes have client do the Valsalva, maneuver, or the like that's what that is. So you pretty much tell the client, pretend you're going to have a bowel movement, right? So we go that whole thing. So that's one of the treatment to help the heart pretty much jumpstart itself. And if none of these non-pharmacological, then we want to go to pharmacological, which would be adenosine again. And if they become unstable, then we go to cardioversion. But you see how we're from least to great? That's a test-taking strategy. We go from least invasive, right, to most. We don't just jump to being aggressive. So keep that in mind. So with this type of question with SVTs, you have to see whether your client is stable or unstable because your intervention is different. Okay? If they're stable, then we can just have them Valsalva, right? We can just have them cough forcibly and Valsalva. If they're unstable, then that's a different story. Then we need adenosine, we need cardioversion. Okay, so the nursing interventions involve those. Of course, I sound again like a broken record. Assess your patient, put oxygen on. Okay, then we can do the vagal maneuver. Cough for me real hard, Mrs. Jones, and bear down. Ugh. If they don't have an IV, put the IV on. Start that normal saline. Then call the physician. And we also do prepare for cardioversion in case we need it. Okay. Let's cover a couple more before you break. So hang in there. It hasn't been an hour. Unless you break in between. All right. So now let's go over atrial flutter. Okay. After we cover the atriums, then you will have earned a break. I know I'm a tough cookie. But you're gonna thank me once you pass. So it's okay if you're not saying nice words right now, but once you pass, I forgive you. So deep breath, hang in there, open your mind, okay? So now we're still in the atrial problems, okay? And it's so funny because all of this, you may not even get an EKG question, but you may. So we don't know. We prepare for everything. So atrial flutter, we're still in the atria and we're still in tachy, okay? What's happening with atrial flutter is that the heart, the firing, right, the electricity is going so fast, so rapidly that it caused these P waves to look sharp like that, to look like what we call a sawtooth. That's a great way of describing this. You know the thing we cut wood with, a saw, right? So it looks like a sawtooth. So you do have P waves with atrial flutter. Keep that in mind. Those are P waves and they're sharp. The other thing you want to look on in your EKG strip is whether you have regular, meaning coming at the same time, QRS. With atrial flutter, you have P waves and you have regular QRSs. Okay? Very common with your COPD, coronary artery disease, your little ones with the atrial septal defect we'll talk about. So this is treated similar to atrial fibrillation. So we'll talk about the treatment for them together in a moment. Here's another picture of that. You see the P waves, they're there. So two things you look at to differentiate between atrial flutter and atrial fibrillation. Number one, do you have P waves? Number two, are your QRSs regular? If you look on here, you count the large boxes, 1, 2, 3, 4.5, almost 5. 1, 2, 3, 4.5, almost 5. You see how they're regular? Same thing here. They are regular. If you count your R to R to R to R, they're regular. So I have P waves and my QRSs are regular. That's a flutter. So now let's look at signs and symptoms and causes. So sometimes this is just from getting old, non-modifiable. You cannot do anything about that. Sometimes it's a valve disorder. Okay, usually your mitral valve is giving trouble. Sometimes it's the wall of the heart that has gotten thick. That's why you saw earlier the atrial septal defect. Look at right here. Oops, this one. You see here how it says atrial septal defect? That's a condition in the pediatric client where there's a hole between their atriums. Okay, so sometimes that's the issue, and that affects the mitral valve. So that makes sense. Dead tissue, ischemia, could cause atrial flutter. Cardiomyopathy, myo. COPD, I mentioned earlier. Emphysema. For COPD, it could be bronchitis or emphysema for sure here. So those are some of the causes of atrial flutter. How do they present? How does the client walk into your emergency room, right? They're palpitating, they're short of breath, they're anxious, they're weak, right? Angina, that pain, syncope, which puts them under the safety umbrella. Okay, so those are the signs and symptoms. You remember you have to spend a moment there to know how these clients present, because sometimes you may, get a client where they say atrial flutter. Other time they may describe, give you a history, give you the risk factors, which we need to get into. So now let's talk about risk factors in treatment, and then we'll talk about nursing intervention. So we want to prevent clot from forming in the atria. Whenever I'm talking to you, I mention a problem with valves, you have to think clot. Because remember, if the valves are affected and not working properly, there's a risk of clot formation. So that would be a complication. Stroke, obviously, pulmonary embolism, that's a risk factor. So whenever you have formation of clots travel. We don't want them traveling because then they're going to block the airway. And oh yeah, definite drop in cardiac output, which you saw is a risk factor for all of that we've just covered. And that's always a problem. So cardioversion, atrial flutter, cardioversion. We talked about that earlier. And we may need some antiarrhythmics, procainamide. So that's chemically what we want to do, procainamide. And you will see a regimen because we want to slow, right, the ventricular rate. So diltiazem, verapamil, digitalis, beta blockers will all be part of the regimen. Because of the thrombus, heparin, we want to reduce that incident. We want to thin the blood. If they already have a clot when they come to us in the hospital, then we may use thrombolytics, but we want to use heparin to prevent future clots, to thin the blood. So those are the treatments for atrial flutter, cardioversion, antiarrhythmics. Okay, now let's talk about intervention. Assess your patient. I know, I said that a million times already. Give oxygen, start an IV, notify the physician, then we prepare to cardiovert. Okay. Let's just cover one more atrial problem, and then we will have earned a break, a legal break, an approved break. Okay, so we just did atrial flutter. So now let's do atrial fibrillation. Okay, so atrial fibrillation, you do not have P waves. These are not P waves. They're wiggly lines, wavy lines. So that's question number one. And just that alone tells you it's an atrial problem. You just have to figure out which one. The other question is that your QRSs are irregular. Look at this. R to R is longer than this one, You see, they're not regular. Do I have P waves? No. Are my QRSs regular? No. That makes it atrial fibrillation. So you have a signal that keeps circling uncontrollably, uncoordinated. You see here, the heart is not beeping, it's quivering. It's not contracting, it's quivering. Okay, the ventricles need regular impulses, nice, strong contractions. Okay, very horrible condition. Now, I really want you to listen to my descriptions with these strips. Why? Because sometimes you get a question where they give you the strip, yes, and sometimes you get a question where they describe the strip. So let's try this question together. And this is why I teach the way I teach, because I want to prepare you for however angle the question comes at you. So a nurse is watching the cardiac monitor and a client's rhythm suddenly changes. There are no P waves. Instead, there are wavy lines. The QRS complexes measure 0.08 seconds, but they are irregular with a rate of 120 beats per minute. The nurse interprets this rhythm as. So do you see how it's not just being able to ID your strip? Yes, that's good because you may very well just be given the strip and be able to tell you're looking at an atrial fibrillation, be able to tell you're looking at an atrial flutter, be able to tell, but it could also be described. Just like this. This is a real NCLEX question, folks. Okay? So this would be an atrial fibrillation that is described. No P wave, irregular QRSs. So great question. I love just throwing questions in the middle of this because I want you to see how sometimes these would be phrased. And by the way, the sooner you practice questions, the better. Okay. So great example here. So now let's go over causes of atrial fibrillation. Hypoxia, similar. Hypertension, CHF, coronary artery disease, sinus issues, sinus node issues, not just sinus node. Mitral valve issues, rheumatic heart disease, pericarditis. So some of this we haven't covered. As we cover it, the information is going to circle and make sense. Hyperthyroidism, excessive alcohol and caffeine, because we're talking tachy. So you see some of these causes are similar to any of the other tachy issues. Signs and symptoms, they're palpitating, irregular pulses, the dizziness, the fainting, right? These are safety, confusion, they're tired, trouble breathing, especially when they're laying flat. So don't put them flat. Okay, elevate the head of the bed a little bit. That chest tightness. Okay, similar to atrial flutter. Okay. Risk factors. What are some of the things we're trying to prevent? We want to prevent these complications. We want to prevent clot from forming. Okay, so we're going to need to thin the blood. That's how we do that. They're at risk for strokes. They're at risk for pulmonary embolism, just like fluttering. Cardiac output, just like fluttering. So they have those in common. The risk factors are similar. Both conditions, one of our biggest concern is that pulmonary embolism is the stroke that's coming. That's why one of the regimen is to thin that blood. So medically, we want to slow that heart rate, absolutely. So part of the regimen, you're going to see digoxin, similar to flutter. You're going to see the beta blocker, similar to flutter. You're going to see the calcium channel blocker, similar, verapamil. So treatment, very similar. The most important one really is the antithrombotic. We want to, if they currently have a clot, we need thrombolytics. So thrombolytics like TPAs are going to bust clots that are currently there, and the heparin is going to thin the blood. So sometimes you'll see these clients on a combination of heparin and Coumadin, because Coumadin takes forever to get to therapeutic range. So we need them on both, and then we wean them off the heparin and we keep them on the Coumadin. So, and we prepare for the cardioversion. So the nursing interventions are the same for flutter versus fibrillation. Assess your client, put oxygen, start an IV, call the physician, prepare to cardiovert. I sound like a broken record, I know. But here's a priority, whether it's flutter or fibrillation. We don't want these thrombotic events. This is a beautiful picture of this. They travel, they block the way, they decrease blood flow. Problem, problem, problem. The sooner we can intervene, the better. And that's why sometimes when these things happen to people and nobody's around, it's not a good outcome. But when people are around and we intervene quicker, we save lives. Okay, so the length and the onset of it is really key to saving somebody's life. But again, sometimes this happens and people, are not around. Like I remember before the holiday, there's a neighbor from my old neighborhood where I was passing by. Sometimes I'll just stop by and visit her because she lives by herself. Her kids are out of the state. I'll just check on her. And I had like a sense to go check on her, but I had a friend with me and I said, no, I can't just bring a stranger to people's house. So I went by, and then when I got to the light, it was just bugging me. And I said that to the friend. I said, but it would be rude. Let me not do that. Days later, her daughter called me. They had found her dead in her home. And I wish I had stopped by, even with the friend, but I didn't want to be rude. And I still think about this every now and then. So next time something like this happens, I will stop by. I will make a U-turn. It would have been better. But I thought it would be rude to just stop by somebody's house with somebody they don't know. So I'm like, oh, and never got to it. So something like this happened and she didn't have anybody around. But from what I understand, she had passed away from days. So anyway, it's good to be around people, especially when you're at risk of these things, so that we can at least call 911 and intervene. Okay, so now we're going to get into treatment. With these questions, you have to pay attention the time frame. Is the client less than 48 hours or greater than 48 hours? It matters. So within the test taking strategies, I've already taught you that time matters. How you treat these clients within the first 48 hours is different when they're greater than 48 hours from their signs and symptoms. The other thing too you want to look at, are you dealing with a stable or an unstable client? Because your intervention is different. You see how these are higher level. You have to know your information, your material, and have a strong foundation on the things that we've pretty much just done in order to answer these questions correctly. So if the client is unstable, we're talking, they're hypotensive. So the treatment would be cardioversion. If you're dealing with a stable client, right, they're not hypotensive, we want to work on controlling that heart rate. So the beta blockers are going to be our primary treatment. Okay, but we're always ready to cardiovert. Okay, and we do prefer electrical to pharmacological. Okay, but if electrical fails, then yes, amiodarone. Okay, you've heard me mention amiodarone over and over and over again because we're talking tachy. So that would be your treatment for acute, less than 48 hours. Are they stable or unstable? And one of the first vitals you're going to look at is the blood pressure. Okay, now, if your client is greater than 48 hours, or you don't know, right? Sometimes that happens. Our biggest concern are the clots. That's really the big deal with this. Think about it, more than 48 hours, so most likely that's happening. So the anticoagulant will be a part of the regimen. We are going to talk about Coumadin warfarin to death. Okay? So they'll need to be on the Coumadin, the anticoagulant for some time. We'll talk about that. You need to know the therapeutic range. You need to know the foods the client needs to stay away from. It's a high maintenance drug. There's a lot to know. Okay? So one of the things we also do is get an echo because we want to make sure there's no thrombus sitting there. If there is, we'll need thrombolytics. We need to bust those clots that are currently there. So the client will be on thrombolytics, they'll be on heparin, they'll be on Coumadin, and we want to be ready for cardioversion. So again, it differs. Is your client, within 48 hours or after 48 hours? The treatment is very, very much different. So now if it's chronic, if the client is chronic, and if they're under 60 years old and there's no history of prior heart disease or risk factors, there's not much we do. We just keep the blood thin. Okay. Yeah, we treat signs and symptoms. So pay attention to the age of your client and their risk factors. And so that would differ from client to client. Now, I love this picture. This is a big clot. Ignore that orange thing there. This is a huge, huge clot. We don't want this traveling. So you already know how these client presents, okay? They're dizzy, they're palpitating, they're short of breath, they're chest pain. We already went over that. Okay, we want to prevent the stroke that's coming. We want to prevent these little thrombus from traveling. Okay, so these small little blood clots, they form from these conditions, whether it's aflutter, AFib, these form from these conditions and they travel. Okay, so this is why these clients need to, for some time, be on these blood thinners. Okay. So let me just test you a little bit on these signs and symptoms so I can see where you are and that you have a nice understanding. So try this question for me based on what I've just taught you so far. The nurse is discharging a client to home with a new diagnosis of atrial fibrillation, which we've just covered. The nurse explained that which of the following is the most important symptom to report to the physician. Now, if you expect it, you're not reporting it. If it's within range, you're not reporting it. If it's normal, you're not reporting it. You get the point. So would I be calling the physician to report irregular pulse, fever, fatigue, or hemoptysis? The correct answer is hemoptysis. And let's go over why. And it's what I've been saying over and over and over again. A complication of atrial fibrillation is the pulmonary embolism. So the hemoptysis is a sign of that. We expect irregular pulse, may or may not be fatigue. They don't usually get a fever with this. So the hemoptysis, I would need to report that. Those are signs of pulmonary embolism. We want to prevent these little clots. Great question. It just goes to show you know what's going on pathophysiologically with this disorder. So I keep saying cardiovert, cardiovert, cardiovert. So in some cases, yeah, we may need cardioversion for atrial fibrillation. That's how we're going to correct this abnormal rhythm. Okay, atrial fibrillation can be corrected with electrical shock to the heart called cardioversion. Sometimes that's our only option. Okay. Some more treatment. This is usually treated with a cocktail, a number of different drugs, right? You're never going to see just one. No, it's a regimen of things that we're doing because we're trying to resolve a number of issues. So one of the treatments you're going to see are blood thinners. We need to keep the blood thin to prevent those thrombi we just saw. These are anti-clotting medications, which decreases that risk of stroke. Those nice, beautiful picture I just showed you. So Leading drug for this is warfarin Coumadin. There's a lot you need to know about warfarin Coumadin. So pocket that for a moment. I'm going to drill that in a moment. We also need to control the heart rate. You're going to see some regimens specifically for that. Rivaroxaban, Xarelto, you're more familiar with Xarelto, but please memorize Rivaroxaban, is a great drug. It's on your NCLEX. It is not as high maintenance as Coumadin warfarin. There's a lot of maintenance for Coumadin, but with Rivaroxaban, take daily with your meal, no blood work, no need to stay away from certain foods. Nope, none of that. And its job is going to reduce the risk of AFib-related stroke. No blood work, no maintenance, which is great. Okay, so let's continue with treatment. So you're going to see the client on some antiarrhythmics, right? And some calcium channel blockers, your dipines. So your antiarrhythmics, amiodarone, I've said at least 5 times already. Fluconide is another one. Ibutilide, I've talked about already. Corvert. Corvert is only, this is an only IV. Lidocaine, only IV. I've mentioned proconamide, propofenon, quinidine, toconide. So what you need to do is minimally be able to classify these drugs, knowing that they are used for antiarrhythmic purposes, minimally. As we continue with the review, if you've already watched some of these other recordings, you'll see some specific information with lidocaine, some specific, but minimally be able to classify the drug, knowing what it's used for, knowing that it's an antiarrhythmic. Your calcium channel blockers, not all, but most of them, right? And then dipine, that suffix, amlodipine, philodipine, nicardipine. With the exception of daltiazem, which I've mentioned a few times already, most of them end in dipine. Okay, daltiazem and verapamil are the two abnormal. They don't end in dipine. Another thing I want to add with your antiarrhythmics, they are grouped by their class. Okay, so there's class 1, 2, 3, 4. So your quinidine, lidocaine, flecainamide, they're considered class 1, whereas your beta blockers, class 2. Class 3, block your potassium channel blockers, amiodarone. Class 4, verapamil and daltiazem. They don't end in dipine like you saw with the other ones. So whenever we put clients on antiarrhythmics, they are at risk of congestive heart failure. So we want to watch them for that. And if they do go into any type of, heart failure, especially if it's right-sided heart failure, they're going to be gaining weight. It's not real weight, it's water weight, right? So that's why we weigh them regularly. And we want to know any type of weight gain. And lidocaine has a thin therapeutic threshold, okay, class 1 antiarrhythmic. So the client could get toxic on it fairly quickly. So we want to, the moment you see confusion and restlessness, that's the beginning of that. You walked in, your client was beautiful, they knew who you were, where they were, and then all of a sudden, who are you? And they're restless. Check the lidocaine level. Okay? We're not done with the treatment. So let's talk about the beta blockers. They are part of the regimen. Very easy. Your betas, not all, but the alol suffix, atenolol, metoprolol, propranolol. I covered these in detail when we go over the antihypertensives. Okay, so in addition to that, you will see an anticoagulant, which I mentioned, warfarin, Coumadin. We're going to talk about in just a moment. The bigger trend, Pradaxa. I mentioned Xarelto, low maintenance. you should be familiar with apexaben, Eliquis, and adaxaben. Do you see a commonality? Zaban, Zaban, right here. Zaban, Zaban, Zaban. So the moment you see that suffix, you should be able to say, okay, that's an anticoagulant. Now let's talk about Coumadin. Yay! You're like, no. Okay, so Coumadin warfarin, as I mentioned, is a high maintenance drug. You may very well get a question on this drug, so pay attention. Number one, whenever we put a client on Coumadin warfarin, it takes days before this drug gets into a therapeutic range. Okay? And when they're on the drug, the way we monitor that their blood is within a therapeutic range, it's not too thin or too thick, is with what we call the INR. Okay, so if they're on Coumadin, we're going to monitor the INR specifically. Okay, we don't want it lower than 2 when they're on Coumadin. We don't want it higher than 3. We want it between 2 and 3 when they're on this drug. Less than 2, they're going to clot. More than 3, they're going to bleed. We need homeostasis. We need a therapeutic range. Okay? If it's too high, yeah, they need to be on bleeding precaution, fall precaution. Too low, oh my, clots are about to happen. We're not doing our job. The whole goal is to prevent that. Now, what makes this even more high maintenance, in addition to regularly taking blood work from the client to make sure that the INR is within 2 and 3, there is a diet restriction with this drug, and it gets not complicated, but there's some things you need to know. So the antidote for Coumadin warfarin is what? Vitamin K. Now, vitamin K is found in so many foods, especially your green leafy veggies. So clients have to be educated to not consume excessive amount of those foods high in vitamin K because it's the antidote. It's going to stop the drug from working. So here's what you need to remember for test questions. The answer is not to tell the client, stop eating anything and everything green leafy, no more broccoli, spinach. No, that's not the goal. When you get the client's blood within 2 to 3 of that INR, it's in a therapeutic range. We want the client to keep the same diet because we got that INR in a therapeutic range with the current diet, whether it be 1 salad a week, 2 salads a week, whatever it is. So tell them, don't change your diet. You don't want them consuming an excessive amount of food high in vitamin K, and on this drug is as if you didn't give the drug because it's the antidote to the drug. It's going to stop the drug from working. You see, I told you this is high maintenance. I'll recap again in a moment. So we've talked about a lot of treatment for atrial fibrillation and atrial flutter thus far. Okay, so quick recap. So right here, cardioversion, blood thinners, your antiarrhythmics, your calcium channel blockers, your anticoagulants, Coumadin specifically. Okay, one more treatment. It's called ablation. I know students have had this on the NCLEX because they tell me afterwards. So this is on the NCLEX, everyone. So you know how we do the outside external defibrillation, okay? Ablation is internal. Okay, so this is a surgical procedure called ablation that where the physician or the surgeon goes internally to provide a low voltage right in the area to fix that atrial fibrillation. So this is obviously last measure. It's invasive, risk for infection, risk for hemorrhaging, lots of risk factors. Okay, but if we're not able to control your atrial fibrillation in other ways, this may be an option. Okay, so a cardiologist, electrophysiologist is going to surgically perform this. Okay, so it's through catheterization. Normally they go through the groin, where they filter this right to your heart, sending a low voltage but high frequency electricity in the area of the heart that is causing the irregularity. It's going to destroy the small amount of tissue causing that abnormality, and it may cure your AFib. Again, that wouldn't be the first thing because we're least to most. That's just how we are. Okay. So all of that was tachyarrhythmias with atrial problems, impulses. Now we are going to cover tachy. We're still in tachy, but with ventricular impulses. You see, this thing has to be organized that way or it just gets too confusing. Okay? So this is the best way to organize this. And while you were in nursing school, you should have had like an EKG boot camp, like literally a whole day. Some schools even do 2 to 3 days of EKG, just EKG. And I'm trying to cover this in such a short period of time. Okay. Now, our first one is supraventricular tachy, SVT. Okay. We did atrioventricular earlier. Now we're doing the superficial. So this could be a little bit of a recap. So some similarities, but that's okay. Repetition is good. And some of these don't fall in under any umbrella. Some fall on both umbrella and some fall, like you'll see, I have some special ones. They don't fall under anywhere. All right, so obviously tachy beats over 140 or 150 even. Let's go over causes with this. A number of causes. So again, find the underlying cause and stop it. Sometimes it's the stimulants, the hypoxia, the hypokalemia. All right, repetition. So this falls under this umbrella again. So same thing, nothing new. It's all the same signs and symptoms, but again, this falls under this umbrella. So be able to put it under both umbrella. Okay, treatments are the same, nothing new, but again, it falls under this umbrella as well. It's just what it is. Okay, so now this could progress to VTAC. This is where it gets different. We haven't covered VTAC. Okay, ventricular tachycardia. So the ventricles are overfiring. So rapid heart rate with, I wouldn't call these QRS complexes. And this is a great way to, here's a great way to ID this strip. They look like M's, right? Cursive M's that are abnormal. So yeah, you can't pull a QRS out of this. And it's so unique that you should be able to spot it the moment I give it to you. That's VTAC. And also look at the fact that they're tall, because VFib are not. I'll show you VFib in a moment. Okay, so ventricular foci rapidly firing, okay, caused by MI, dead tissue, hypotension, drugs could be a problem for this. This usually starts off with a pulse, okay? But if unaddressed, it could rapidly turn into a pulseless VTAC, which is a big problem. Now, in your question, pay attention whether you're dealing with a pulse client or a pulseless client, because your intervention is different. So you have a ventricular tachycardia. Do they have a pulse or do they not have a pulse? If they have a pulse, amiodarone, because we're still talking tachy. If they do not have a pulse, call a code. If you're not at the hospital, you call 911. You get the AED, right? Your CPR mode goes into play. If you just renewed your CPR card, they should be fresh on your mind. So pulse or no pulse? Pulse, amiodarone. No pulse, call a code. Okay, start your CPR, defibrillate, epinephrine, amiodarone, lidocaine. Yep, But also, always pay attention, what setting are you in? Because depending on your setting, don't always expect to be at the hospital, right? Sometimes they give you a patient, they're at a school, they're at the supermarket, they're at a community meeting, right? We can put a patient anywhere. We could put a patient in the middle of the highway, right? And that's a real question. You, the nurse driving in the highway, there's a car accident. Those are usually about the Good Samaritan. Do you stop and help? No, you don't have to. That's if you watch my management of care session, you'd know that. You don't have to. But back to this. So pay attention. Do I have a pulse or do I not have a pulse? But let's go over causes. There's usually underlying heart diseases with those, especially MI, right? Myocardial infarction, dead tissue to the heart, ischemia. Some medications, especially medications that prolong Q to T intervals. VTAC. We just talked about VTAC, or we are talking about VTAC, the patho. Electrolyte imbalance, DIG toxicity, okay, digitalis toxicity, CHF, a lot of causes. So how do they look? How do they present? That chest pain, because we're talking some of the causes being in MI, right? Being angina, chest pain, syncope, lightheadedness, palpitation. You see very similar to all these other signs and symptoms for tachy. And if we don't address that, loss of consciousness, and they could potentially die. So complication, sudden cardiac death, which leads to death. So that's why we need to intervene cardiac-wise and get the heart back to a normal rhythm. So again, treatment, if there's no pulse, call a code if you're in the hospital, start CPR, follow your ACLS protocol. If there is a pulse, then we address it chemically. Okay? If they're unstable, cardiovert. And then we start the regimen, the amiodarone, the lidocaine. And the others is going to depend on the sign and symptom. They may need all these extra antiarrhythmics. The ablation we talked about earlier. What is our nursing intervention for these folks? Right? Test questions from there. Lots of test questions. What do we do? How do we help them? How do we, keep them alive? Number one, assess your client. You already know that. I've said that at least 20 times. If they have symptoms, we are always aggressive. We are always quick. We are like, you have very, very little time to save this client's life who's in VTAC. We want to avoid VFib because if this is ignored, VFib is coming. And VFib, you're going to see, is very dangerous. Okay, if they have a pulse, put oxygen on them, start an IV, monitor them closely, and we're giving all these wonderful drugs. If they're pulseless, yeah, we start our code, we start CPR, we defibrillate, IV, yes. So, but pay attention what setting they're in to tell you what's the first thing you do. If you're outside of a hospital, like even if you're in the regular med surg floor versus ICU, what you do is different. Because with ICU, you don't need to call a rapid response. You can, you have everything there to code the client. If you're in a regular med surg and they start to decline, then you call a rapid response and then we call a code, like we graduate up. So pay attention in the setting that you're in. So this is a VTAC client, if ignored, goes into VFib. You see how VTACs are tall? That's a great way to ID that strip. They're tall. They're tall. VFibs are not. Look at VFib. They're not tall. And I don't know how you want to describe this, but the moment you see it, you should be able to ID it. The heart is not beeping. It's quivering. And VFibs are always, here's an absolute, right? You are so used to waking up when you see absolutes. Now I can't say them without you being like, oh, that's an absolute. VFibs are always pulseless. Start a code. That's it. There's no start a code, call a code, initiate it, get it going. Yep. So VFib initiates from VTAC. So you have less time with a VFib than you have with a VTAC. They're both bad, but you have less time with a VFib. Acute MI is a problem. Untreated VTAC is a problem. Electrolyte hypothermia, MIs, drug toxicity, trauma. So some of this we can eliminate and fix, right? Like the electrolyte imbalance, easier fix than the others. But they're going to be losing consciousness. They don't have a pulse. That's how they present. And if we don't do anything, the complication is death. But the treatment is to, yeah, get that CPR going. Be ready to defibrillate. For us, test questions, nursing intervention. So with these clients, they're obviously critically ill. You're not going to have them and a whole bunch of other clients. So because they need that one-on-one, okay? They need that one-on-one. We want to always be monitoring the strips with these. And yeah, you can't have this client and a whole bunch of other clients. This is, yeah, just your one client because we're constantly, yeah, we're staying with them. We're assessing them. We're looking at that strip. Yeah, we're checking them frequently because they could, yeah, code on us any moment. We need to be ready to defibrillate. Make sure we have more than one IV line, large bore. Okay, so critically ill client. Now I have a couple of slides that not only they don't fall under any of these, but students have said they've had these slides on the real exam, okay? And I believe two-stat de print is very easy to ID because you see as these are going in different directions and it looks like that in real life. Like, and this is like the strip you get. So you can't mix this. And it's not like a VTAC you saw earlier. The VTACs were more defined, even though they were these M's. This is two-stat de print. So this is a polymorphic VTAC, multiple foci, as you can see, going in multiple directions. This is an electrolyte problem. Pull a chem panel. We want to pull a chemistry panel ASAP. You're going to look at the magnesium and the calcium. Okay, and these clients are usually hypo. So easy to fix too. So this slide is two-stat de point, the French word. And it's an electrolyte problem. Let's look at some of the other causes, but one of the main cause is an electrolyte problem. So they'll have a prolonged QT. Sometimes it's drugs issues as well. Your phenothiazides and your tricyclics, your antipsychotics are a major issue. And as I mentioned earlier, the electrolyte problem, hypokalemia as well, hypomagnesemia, hypocalcemia. So pull a full chem panel. Okay. So once we ID the cause, we can treat that, which is great. But if untreated, death. They're going to have chest pain, lose consciousness, nausea, shortness of breath. Again, it can be treated, but if it doesn't, death. Okay, we may need to start CPR on them, eliminate the factor if we can figure out what it is. If it's an electrolyte imbalance, we can easily fix that too. So if they're hypo, we can give them hypertonic solution with the electrolyte in there. Yeah, if it's hypomagnesemia, bolus with high levels of magnesium, bolus with high levels of calcium, bolus with high levels of potassium, which we run very slow, by the way, because and it burns and it could stop their heart. So, by the way, all of these clients, should have mentioned that earlier, they're always on an EKG monitor, especially when we're giving cardiac meds. Always. You're never going to give these medications, treat a client like that, and they're not on a continuous, ongoing EKG on a telemetry floor, right? If they're stable and they're transitioning, but in the ICU, yeah, they're just on those monitors. Okay. A couple of nursing interventions, of course, assess your client, make sure the leads are attached, they didn't come off the IV, that goes without saying. Okay. Our last strip, which you should be very well familiar with, asystole. Now, there's a couple of test questions where they're checking to see that you, number one, know their strip, but that you don't mix it with a disconnected um, lead. Because a disconnected lead is not going to be flat like that. There's going to be some, wiggly something. So be sure to ID this. Your asystole is flat, 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 flat. Okay, so this is a client going into that. Now, test questions. This rhythm, or it's not really a rhythm, but for the lack of a better word, the asystole will not respond to defibrillation. Remember, we defibrillate when there is abnormal rhythm. So it's going to shock and jump start that abnormal rhythm. If there is no rhythm, which is what's happening in asystole, there is no rhythm. It's not like it's abnormal. We can jump start and get it normal. You're too late here. There is no rhythm. So your external defibrillator, your AED, automated external defibrillator, will not work. It's not going to tell you clear to shock the client. There's nothing to shock. There's nothing to jumpstart. So test question. The AED will not tell you clear. And don't forget, there's another test question that's floating through my mind. As you put the pads on these clients, you need to make sure nobody's touching the client, because as it shocks the client, anyone touching the client will also get shocked. Now, as nursing students or graduate nurses, you don't have a life. You're only going to do the necessities that you have to do. If you have to work, if you have to do certain things, yes, the have tos. But other than the have tos, you don't have a life. That means you're not watching TV just to watch TV. If you do watch TV, you want to watch stuff that's going to help you pass NCLEX. And one of the shows that would do that is Untold Stories of the ER, one of my favorites. There is an episode where it's a seasoned nurse and a new RN in the ER, small town. And this lady comes in with her husband who's having cardiac issues, and they put the pads on the client, and the new nurse forgot to say clear and shocked the client, but the physician was touching the client. And so the physician jumps, like the voltage lands on the floor on the other side of the ER. So everybody's freaking out, right? The seasoned nurse, the new nurse, the wife. So then the seasoned nurse leaves the patient to go attend to the physician who's on the floor. And the wife is going, "What about my husband?" It's the most, and it's a true story. So I think you should watch that show. There's lots of test questions. I love watching it. And it's so funny. My family's tired of me saying, "That's a test question. That's a test question." But please don't watch Grey's Anatomy. Hopefully that's not one of your favorites, but those are not the ones that are going to help you pass NCLEX. Okay, after you pass NCLEX, then you can go back to those shows. But yeah, you have to make sure no one's touching the client. If not, everybody gets shocked, whoever's touching the client, okay? For asystole, you're gonna inject them with as much epinephrine and atropine as you can, but sometimes it's a little bit late. So a lot of causes, obviously, right, that could progress a client to asystole. Okay, if you have an extensive amount of dead cardiac tissue, yeah, that's the problem. Acute MI, yep, that could get you to asystole. Failure of your pacemaker. Cardiac tamponade, we haven't covered, we will. Prolonged VFib, we just talked about. Pulmonary embolism. So there's no pulse, no measurable blood pressure, so they've passed, okay? Nursing intervention, you're still going to assess. I know, yes, you're still going to assess. Okay, make sure the leads aren't loose, right? You see this and your client is walking, talking, then obviously this isn't, they're not asystole. So yeah, we can start the CPR, but if there's no rhythm, it's not gonna. All right, there are a few more. I know I said this was the last one, but I forgot that I added PVCs. So don't move. All right, so PVCs, just real quick. This one is not heavy like the other ones. So this is an abnormal, and I added this because a student recently said they had it. So obviously abnormal firing, but it's random with this one, okay? But these clients end up with these wide QRSs, contractions, right? So this could be nothing. Often patients don't even have any symptoms, but it does need to be monitored, okay? So it may not progress to anything, but it could be something. So this requires monitoring because it could progress, right? Premature, hence the name, PVCs, premature ventricular contraction. So prematurely, before they should, these clients are having these ventricular contractions. So it could prolong, or client could end up in VTAC and VFib. So we want to monitor this client, especially if they're having more than 6 of them per minute. And obviously if they have symptoms, but for the most part, we watch these clients with PVCs, okay? Unless they're having more than 6 or they have symptoms, then we would intervene, okay? Okay, so let's go into not many test questions with this one. We're gonna get into the disorders with the pericarditis, and you don't get 12 lead EKG questions. All right, let's go into this just a little bit. I know you probably need a break. Don't pause yet. When you have an ST elevation, we want to address that because it could be from an MI, which we're going to cover myocardial infarctions in a moment. So, like with these clients, we're talking like blockage to the heart, like with coronary issues. We're talking about these type of blockage. So we would want to keep them on this monitor. We want to pull their enzyme. So we're going to talk about some of these conditions that will cause this, like pericarditis. But sometimes we want to look, is it a STEMI or non-STEMI, right? With the myocardial infarction. So this is the difference between a STEMI and a non-STEMI, right? And STEMI. It's your STEMIs, there's complete, like you see in this picture here, total blockage. You can think of this similarly to an angina, which is partial occlusion, and an MI, which is complete occlusion. Okay, so with a STEMI, okay, with the ST, complete and prolonged occlusion, which obviously is worse. Okay, and a non-STEMI, so there's a little narrowing, right? But there is still passageway. Okay, but it's just narrowing, so that decreases blood flow. Okay, so here's this slide explains it a little bit more in detail. So with your STEMI, ST elevation MI, so if the time from these symptoms are more than 12 hours, we want to follow a non-STEMI regimen, less than 12 hours. I'm sorry, more than 12 hours. Then we're going to follow a non-STEMI. And the protocol differs if it's less than 12 hours. So don't expect to get questions from there because that changes from facility to facility to facility. Okay. But we want to do the heparins, the beta blockers, same regimen we talked about earlier. We're always pulling troponin levels. We'll go into troponin levels in details when we actually talk about an MI. Okay. So if they have a normal or non-diagnosed EKG, then we're going to keep pulling that troponin level. When we talk about an MI, I'll revisit that. So, but for now, what you need to remember is a STEMI is a complete occlusion, where non-STEMI narrowing of the passageway. Okay. Okay, so sometimes you get clients with prolonged QT, I mentioned briefly earlier. Okay, those are usually electrolyte issues. Okay, low magnesium, I mentioned this with the Toussaint de Point. So if you have a electrolyte issue, you may see a prolonged Q to T interval. So those clients, we need to pull a chemistry panel. We want to see what the magnesium and the calcium. So often to your hypopara clients, right? Because their calciums are low. And when we put an EKG on them, that's what we're seeing. So if it's a medication that's doing it, then they need to get off that drug, right? And they need those electrolytes. So some class drugs cause this. And some of the anti-arrhythmias we just talked about, like quinidine, procainamide, lidocaine, fluconide, they cause a prolonged QT. It is what it is. So we want to look out for that if we have to put a client on these drugs. Your antiarrhythmics class 3, I just talked about. I've been talking about amiodarone. Yeah, it causes a QT prolongedness. Your neuroleptic drugs, your seizure drugs, your antipsychotics, your tricyclics, your macrolides, those antibiotics, they cause a prolonged QT. Okay? Hang in there. I mentioned the Valsalva earlier, the bearing down. Sometimes we need to do that or teach clients to do that in order to jumpstart the heart, right? You bear when you try and lift blowing through a straw is another. I don't want you to see these options on tests and be like, oh, that's weird. I would never choose that. Yeah, that's not what you're used to. That's not the common, that when you do question, but yes, these are treatment. Coughing forcibly. I mentioned the carotid massage earlier, and I told you I was going to cover that. Here's a nice picture of that. What you need to remember is that that is sometimes contraindicated. You would not do this if there's any occlusive problems, because you'll dislodge whatever it is and it's going to travel. You could cause bleeding, or if they already have a history of bleeding or stroke, or they're elderly, the carotid massage is contraindicated. Okay? Try this question. When ventricular fibrillation occurs in a CCU, critical care unit, the first person reaching the client should the first person reaching the client administer oxygen, defibrillate the client, initiate CPR, or administer sodium bicarbonate IV? Pay attention where you are, because where you are changes what you do. You are in CCU. So if I'm in CCU, I can defibrillate the client because of the setting that I'm in. So ventricular fibrillation, which was my question's problem, is a deep producing dysrhythmia. Death producing. You already know that. We've already covered that. Yep. You don't do anything. Death is what's after that. Once we've ID'd that, they're in VFib. We need to defibrillate. You're in CCU. You don't need to call the physician and get an order. Nope. You're in CCU. So this is what I mean by pay attention to your setting. And don't expect them to spell out CCU, right? So be familiar with that. That's one of the things we make you do at the beginning of your nursing program, is learning these. So sometimes, yeah, they might say critical care unit, intensive care unit, or they might say PACU, NICU. Okay. This little slide is one to remind you about your electrolytes, okay? How they affect your EKG. So when they're hypokalemic, that T is going to be flat or dipped. When they're hyperkalemic, it peaks up. When they're hypocalcemic, which I mentioned earlier, prolonged QT. Hypomagnesemia, prolonged QT. Okay. Hypercalcemia, short ST. So this is a nice little slide to remind you of all of that. Okay, so before we go into pediatric cardiac anomalies, I think we can take another break, short break. Okay, so we are resuming with the pediatric cardiac anomalies. So the way I do this is with every system, you will see me do the anatomy, the physiology, go over diagnostic tests and some general test taking strategies. And then you will see me cover the pediatric abnormalities, and then the adult. So that's what we're going to do here. We're going to cover the pediatric cardiac anomalies first, and then we will continue with adult concerns, okay? So in general, with the pediatric client, generally when these students, I'm sorry, not students, children, because I have so many students, but when the children, these children, even in utero, when they have cardiac issues, we can tell in utero, number one. But the other thing we have to keep in mind is that as the child grows, they usually have some abnormalities where they don't meet their developmental stage. Okay. So we'll talk about that in a moment as well. But let's talk about some of the causes. Okay. So some factors affecting the child in utero could be if the mom consumes alcohol, if the mom is over 40. If you watch the health promotion, the OB section, I talk about, once a woman hits their 35 years and older, then it puts the child at risk for cardiac anomalies and chromosomal issues with the unborn child. That's just how that is. Diabetes, mellitus, sometimes it's genetics. For example, I have a cousin who has a child about the same age of my second one, but when the child was about 2 months old, the child ended up very out of breath, ended up hospitalized at Joe DiMaggio. And long story short, it turns out that the right side of the baby's heart was not contracting. But it turns out that that's what the paternal grandfather died of. So that's a genetic, right? Passed from family to family. Sometimes that's what it is. And like I mentioned earlier, chromosomal. So those are some of the potential causes for those cardiac anomalies we're going to talk about, okay? But findings, how do these children look, right, as they get older and older and older? This is what I was talking about earlier. You need to be aware of these things. These children with cardiac anomalies, they usually have what we call failure to thrive. So failure to thrive means they don't meet their developmental milestone. So like by the time a child gets to be 2 years old, they should be able to, go up and down the stairs, hop on one leg, ride their tricycles, without being excessively out of breath. These children are not like that. They can't do all that I've just mentioned, okay? And definitely not without being overly exhausted. So they have exercise intolerance. They can't you know, get into sports and things like that. They're dysmic. Even when eating, they're out of breath. Okay. Now, the older children that are walking with cardiac anomalies, they do a little defense mechanism called, it's squatting. Literally, they squat, they drop to the floor. Why do they do that? They're shunting blood from non-vital organs to vital organs. And it's a defense mechanism they naturally build. No one teaches them this because they feel better when they do it. Now, whenever, not just children, whenever people in general have conditions that deprive them of oxygen, they end up with what we call clubbing of the fingers. Okay, so the nail bed gets bumpy. Okay, so you have them do this and it's bumpy. They have this 180-degree bump. That's clubbing of the fingers. There's blue cyanosis. Some conditions may even cause them to be pale. The whole point is because they have poor perfusion due to these conditions. And they have unusual pulsations. We're going to talk about coarctation of the aorta. That's where this one fits for sure. Their pulse is different in their head, their arms, and their legs. Okay, so those are some of the findings. Now, for pediatric cardiac anomalies, there are two groups, two umbrellas. There's an umbrella of disorders that are called acyanotic. The A before the word cyanotics means without. So without the cyanosis, the blue discoloration, those are the pink babies. Acyanotic problem. They're pink, these babies. Okay, and those conditions are the patent ductus arteriosus we're going to talk about, the atrial septal defect we're going to talk about, and the ventricular septal defects. We'll talk about all of those. Those are acyanotic defects. Okay. Now, there's another umbrella, I'll come right back, called cyanotic defects. These babies are blue. So don't mix them. Some conditions fall under acyanotic conditions. We'll cover all of them. And other conditions fall under cyanotic. Okay, acyanotic, they don't have cyanosis. They're pink babies. Cyanosis, they're blue. Okay, so again, you're going to see why you don't want to mix these disorders. So the acyanotic problems are what we call left to right shunt. So remember all that beautiful anatomy I went over earlier. Here's where you need to bring that back to memory. So left to right shunt. On the left side of the heart is red blood, oxygenated blood. To the right side, which is blue blood. So the child's blood with these conditions we're going to talk about, they lose a little bit of their red blood to the blue side, but they still have nice red blood flowing throughout their entire body. So your acyanotic defects are left to right shunt, meaning red blood, they lose a little bit of their red oxygenated, rich in oxygen blood to the right side. So now let's go over these actual conditions. So the first one is atrial septal defect. Think of the name, atrial, so it tells you you're talking about the atriums, not the ventricle. Okay, atrial, between the atriums, septal is a hole, just like in this picture right here. You can see my cursor going back and forth. Atrial septal defect. There is a hole between the atriums of this child's heart. Again, we can see this in utero. While they're in mom's belly, we can see this. So that's not normal. And you see how red blood is going to the blue side. So they lose a little bit of that. But there's lots of red blood going through the aorta. That's why they're pink. They're not blue. That's ASD. If it's mild, the child may not even show any signs and symptoms. Ventricular septal defect, same thing, bottom here. Ventricular septal defect, there is a hole between the ventricles. That's all. So depending on the size, you may hear some murmurs. Okay, they're losing a little bit of the red blood. The other condition is PDA, patent ductus arteriosus. So right here underneath the aorta, there's a hole. Now this is normal in every child. But when the child is born, the baby's born and they cry, wah, right? They take their first deep breath. This shunt is supposed to close. So with these babies, it does not, okay? So this one we can fix with pharmacological intervention, with medication. But generally, when children are born, they're born with that, and then once they cry, they take their first breath, it closes. But some children, it doesn't, okay? So our drug of treatment is indomethacin, okay? So treatment for patent ductus arteriosus is indomethacin. So what indomethacin does, it stops, inhibit prostaglandin. When prostaglandin goes down, the duct closes. If indomethacin does not work, surgery. Oh, by the way, the others are all surgery. There's no drugs for them. There's no drug that's going to help your atriums or your ventricle, okay? But the PDA, yeah, we'll do indomethacin first, and then if that doesn't work, then they don't have a choice, surgery. A few more rather, three more, a few more acyanotic defects. Let me cover these two first, these two, because they're just so much easier, and then I'm going to spend a moment on coarctation of the aorta. So sometimes there's decreased pulmonary blood flow, right? Blood to the lungs, because the aortic valve is stenosed, or the pulmonary valve is stenosed. Okay? rigid. They get hard and rigid. They don't flap beautifully like they're supposed to. So that does decrease a little bit blood flow. If it's the aortic, if it's the aorta, it's through the aorta. If it's the pulmonary, it's through the pulmonary. But the child is not without oxygenated blood. Okay. So those are still considered acyanotic. Now, I cannot tell you how many students in the past. I've been doing this NCLEX for 14 years, more than that because I was pregnant with Gabriel. He's 14 now. So more than 14 years. I cannot tell you how many students have had the coarctation of the aorta question. Okay. But after this, you'll never get it wrong. So what's happening with coarctation of the aorta? Coarctation means squeezing. Okay. So there is an obstruction in the aorta. So here's a picture, those of you who are visual learners. You see how the aorta curves, right? You see the branching to the head and to the arms. The squeezing usually happens after the branching. Okay? So this child's blood pressure is going to be higher in their upper body, their head and their arms, but lower in their lower body, their feet and their legs. So with coarctation of the aorta, increased blood pressure in the head and arms, but decreased lower blood pressure in the feet and legs. Their temperature is cooler in their lower extremity. They may be in mild heart failure. The older children that can tell you, they're going to tell you, I have a headache. Yeah. They're going to be dizzy and fainting. Okay. And you can see why they have a headache. Look at the, let's go to this one. Look at the picture here. You see as the heart contracts, so that blood is going to go nice and strong to the head and the arms. But then after the squeezing, it's like, you know, it's working too hard. So that's what's happening with coarctation of the aorta. Okay. So now all of that was acyanotic problems, pink babies. Now we need to talk about cyanotic problems, blue babies, cyanosis. So these are right to left shunt. Now that's the problem. We're talking blue blood, deoxygenated blood, going to the red side and then going to the body. That's why they're blue. Okay. So we're going to talk about tetralogy of Fallot. And these babies have TET spells. Okay. You see, the face is blue. It's not just acrocyanosis, where it's just the little, you know, fingers and toes, which most babies are born with acrocyanosis, but we don't want central. We don't want your lips. No, we don't want central cyanosis. That's a problem. Okay. So let's talk about tetralogy of Fallot. Okay. Oh, this is a coarctation one. I have to move that. Okay, let's talk about tetralogy of Fallot. So with tetra, there are several abnormalities. Let's go through them one by one. Okay. Problem number one, you see the pulmonary valve here and trunk. It's not on the side that it should be. And not only that, it's narrowed. You see, blood cannot go through that tiny. That's problem number one, narrowing of the pulmonary valve, which makes it hard for blue blood to get to the lungs, deoxygenated blood to get to the lungs. Problem number one. Problem number two, the thickening of the right ventricle wall. That's too thick, so that causes the right ventricle to get smaller and smaller and smaller, which pushes blood, blue blood, to the red side, okay, to the left side. So problem number three, you see the aorta, it's displaced. It's supposed to be 100% to the left side. See, it's like in the middle. That's a problem. The biggest problem, however, in addition to all these three horrible abnormalities I just mentioned, they have a VSD. They have a ventricular septal defect, which pushes blue blood to the left side. Because normally, as the heart contracts, remember the left side works harder than the right side. So normally, as the heart contracts, blood will go from, the left side to the right side. But this is opposite in this case because of that large VSD with the small right ventricle that causes blue blood to go on this side, and that now in turn, blue blood goes up the aorta. So this child's having deoxygenated blood floating through their body, okay? Because it's a right to left shunt. So they have decreased oxygen to their entire body, which causes severe cyanosis, and they're at risk for thrombus, the clot, which we've talked about so much. So that's an issue. They're going to have murmurs. They're going to have failure to thrive. This has to be fixed with multiple surgeries. Okay, so that's tetra. There's one more cyanotic defect you need to be familiar with called transposition of the great vessel, TOGV. So transposition of the great vessel, you have to wonder, what are the great vessels? It's the pulmonary and the aortic that are the great vessels, and they switch places. Transposition. You see, this is the pulmonary that's supposed to go right here receiving blue blood. And this is the aorta that's supposed to be right here receiving red blood. You see how they switch places? So this child has blue blood circulating back and forth throughout the body and red blood circulating to the lungs and back. That's transposition of the great vessel. Okay? So these cardiac anomalies for these children need to be diagnosed, right? So we can confirm what we're dealing with. So they're gonna have an EKG done. You know, EKGs are non-invasive. We just went over them. They're painless. Okay. So children that don't understand and can't, keep them on, they may need to be sedated a little bit. Now, another diagnostic test that we use with these conditions is called cardiac catheterization. So literally, a large bore catheter is filtered by the groin of that child. We do it in adults too. But for the children, if there is ever a diaper rash, that procedure cannot be done. And here's why. Test question. Never, ever, ever, ever perform a cardiac catheterization if a child has a diaper rash, because we go via the groin. That's the best place. If they have a fungal infection, a diaper rash, we're piercing the skin to get to that blood vessel. It is too great of a risk to introduce a fungal infection into the bloodstream. That is too great a risk. Sepsis, death. So we will never do a cardiac cath with a diaper rash. Never, ever, ever. Don't get that question wrong, okay? So if you have a child who's non-compliant with any of these, we may need to sedate them, okay? But those are some of the diagnostic tests we do for these conditions. So now what are some nursing interventions, okay, with these babies? So first of all, remember the child is not your only client. It's the family, right? It's mom, dad, whoever is the caretaker. You're caring for the whole family. You want to make sure you explain these procedures to everyone. I know you already know that. But when we're dealing with these type of conditions, it's not just the physical. You need to also think of the psychological process and the emotional toll on the child and the family. Okay, we want to make sure everybody's adjusting, but let's stick to the physical. Number one, adequate oxygen, right? We need to put oxygen on them pulse ox. We're always monitoring the oxygen in addition to the blood pressure and the heart rate. Okay, we want to teach everybody about signs and symptoms and how to manage them. We want to teach the parents about developmental stage and milestone. We want the child to be able to do as much as possible, even with this condition, but without overexerting the heart. Okay. Our goal is for them to be at their maximum with their heart function based on the condition. Okay, we don't ever want them accumulating fluid. So these are, babies, children we're weighing regularly. Okay, so I mentioned earlier, it's extremely important to not stress their heart. So that means you're doing everything for them, especially at first. Even eating exhausts people. Okay, So think about that. That's why sometimes we put a nasogastric tube, right? Because we don't want them exhausting the heart just by trying to eat and feed them. So we're talking that extreme measure. Okay. So a couple more nursing intervention. As far as the treatment with the digoxin, the diuretics, the ACE inhibitors, I will cover those drugs and what you need to know in detail when I cover the adult because the information is not different. Okay, so pocket that for a moment. So all of these clients, you're going to monitor weight, vitals, they're on a pulse ox, right? INO. We're pulling a chemistry panel. We always want to know what the potassium is doing. That is your priority electrolyte with cardiac clients. I need to know what the potassium is doing. I need it within a therapeutic range, especially if the client is on digoxin. And we'll talk about why when we cover digoxin. You never want them hypo because they'll be toxic on the dig if they're hypokalemic. Again, conserve their energy. Okay. Make sure they're not in pain. When people are in pain, the heart gets stressed. Okay. If we need to put a nasogastric tube in when they're eating so they don't overexert themselves, nutrition is important, but we may not allow them to do that by mouth. For the baby, small, frequent meals. We may need to restrict fluid because we don't want them retaining fluid, especially if they start to go into heart failure. Now, test question. There is a special positioning for these children. I have a positioning webinar that I did. So if you find yourself getting positioning questions wrong, take a look at that so you can fix that. So these, like the babies, they need to be in their car seat. Literally put them in their car seat. And then we even do like a little knee chest. Like we literally take their little feet and we push it towards their chest. So we're squatting for them because they're too young to do it. The older children do it. Okay, so we like to put them in a slant position with the head elevated because we don't want aspiration either. Older babies and infant seat, okay, need chest them to shunt the blood from the lower extremities to the higher extremities. Okay, and test question. Any child, adult with cardiac anomalies or history of cardiac problems, you'll hear me say this over and over and over again. Whenever this client, for the rest of their lives, need to have dental work or procedures, surgeries that involves the bloodstream, they need to be on prophylactic antibiotics. They need their dentist to know, they need whoever to know that they have a cardiac issue, history of cardiac issue. They need to be on prophylactic antibiotic to prevent things like endocarditis, which we haven't covered, but we will. Okay, because they're at high risk for that. So for the rest of their lives, they need to do that. Okay. And you know already, once we start somebody on antibiotics, they need to take the entire dose or else it may not work the next time they need it. Okay. A couple of conditions that are not as popular that falls under the cyanotic. We covered tetra, we covered transposition of the great vessels, truncus arteriosus, not as popular, but just know that it's a cyanotic. Okay, tricuspid atresia, it's a cyanotic. It makes the babies blue. Okay. So recap, there aren't a lot under this umbrella as far as disorder. This is all of the disorders, okay? So just to recap, remember that there's two umbrellas. There's a cyanotic and then there's an acyanotic, okay? Your acyanotics are pink babies. That's the patent ductus arteriosus, the hole under the aorta where they're leaking a little bit of red blood, but they still have red blood flowing through their entire body. Atrial septal defect, a hole between the atriums. Ventricular septal defects, a hole between the ventricles. And you also have these two, the aortic stenosis and the pulmonary stenosis. And then the big one, lots of test questions on coarctation of the aorta. Not lots, but one for sure, with you knowing the difference between the blood pressures from the top and the lower. Okay, very different. Very high in the head and arms, but low in the lower extremities. And they're even cooler in the lower extremities. Okay. And this is a nice visual with that. Your cyanotic, they're blue, they're squatting, they're clubbing of the finger, they're syncope. So I've seen several multiple choice and select all that applies. So this is a great one. Remember your case studies again. They want to see that you know the difference between these and you're not mixing them. So you may very well get a cardiac anomaly child, and they said, okay, the nurse is pondering, you know, the difference between cyanosis and acyanosis, and they list all these signs and symptoms, and you need to be able to tell me which ones are affiliated with cyanosis, which ones are affiliated with acyanosis. Okay, and I could reverse that. So be clear on these two umbrellas, okay? And don't forget the developmental milestone. So often they're testing to see that, you know, this is not a child who can, you know, grow up and be a football player. That contact sport is not for them. Okay, there's a lot of conditions. You're going to hear me say that with the children. No more sport. Mono is another one. Cystic fibrosis, right? Like these conditions, these children cannot play contact sports or risk anybody with a shot, right? The with your children that have all this excess fluid in the ventricles of the brain. They have to have a peritoneal shunt. They can't play contact sports. So there's lots of conditions. You're going to hear me say that over and over and over again. They're testing to see that you know that this child cannot be in a sport where, you know, yeah, that's a problem waiting to happen. And pay attention whenever a condition is causing thrombus. Okay, that's an issue. That clot is very dangerous. Don't forget the cardiac catheterization, never with a diaper rash. You will not introduce a fungal infection into the bloodstream. That is sepsis waiting to happen. Okay. All right. So adult conditions are next. So let's pause here.